buenos días a todos. Hola Darío, ¿cómo están? Un nuevo
Hola, Cari.
sábado, ¿cómo están? Después de tanto tiempo nos volvemos a conectar todos. Es hermoso ver los mensajes que estamos recibiendo, se están conectando desde distintos puntos del mundo, Darío.
Sí, sí, la verdad que sí. Buenos días a todos. Como dice Cari, nuevamente nos encontramos un sábado para comenzar un nuevo curso online. Así que bueno, muchas gracias a todos por conectarse desde todas las distintas partes del mundo.
Y ahora queremos presentar al director de Umberto Veronesi Academy, que es el doctor Gabriel Farante. Él es médico mastólogo cirujano de la división del Instituto Europeo de Oncología de Milán. Gabriel, te damos la bienvenida y te escuchamos. Gabriel, ¿nos estás escuchando?
Sí, perfectamente. ¿Me ven?
Sí, te vemos,
Ahí,
Gabriel.
ahí tenemos
Perfecto.
bien.
Un segundo. Ok. Muy buenos días a todos los médicos participantes, a los ya presentes, que son numerosos, y a los que se vayan sumando durante el transcurso del programa. Solo 5 minutos para la introducción de este curso. En el año 2010, hace 13 años, la Universidad de Lérida o de Lleida, al norte de España, cerca de Barcelona, una de las universidades más antiguas de Europa, fundada en 1300, homenajeó al profesor Umberto Veronesi como reconocimiento a su contribución a la ciencia médica, a la oncología y al cáncer de mama, con el título de profesor honoris causa. En esa ocasión, el profesor Veronesi dio una conferencia magistral en la cual pronunció la célebre frase expresando que la ciencia sin investigación es ciega y sin educación es muda, indicando que estos dos son los pilares sobre sobre el que se fundamenta el progreso de la ciencia, y una vez más la UBAC, ahora la Umberto Veronesi Academy y la University of California San Diego, estamos honrando su filosofía con la realización por cuarto año consecutivo de nuestro curso de actualización en cáncer de mama. En este sentido, quiero resaltar un aspecto que muestra la solidez y el peso científico de nuestra propuesta educativa. Se trata de un aspecto objetivo, pues el grupo de 13 docentes y conferencistas que se van a distribuir entre este sábado y el próximo sábado pertenecen a instituciones que representan la élite mundial en la oncología. La comunidad científica internacional concuerda en que el Memorial Sloan Kettering de New York y el MD Anderson de Houston son los dos centros número uno en la oncología internacional, así como el prestigio indiscutido de la Mayo Clinic de Rochester. Y en Europa, nuestro Instituto Europeo de Oncología, que ha dejado constantemente su impronta en el manejo del cáncer de mama, ya desde su creación en 1994 con los estudios científicos de Veronesi sobre la biopsia del ganglio centinela. Veronesi, que en 1982 había impactado al mundo con su estudio sobre la cuadrantectomía. Hoy en día, estos aportes científicos del IEO, del Instituto Europeo de Oncología, se continúan con las investigaciones que realiza el grupo del programa de cenología del IEO, dirigido por el profesor Paolo Veronesi, con dos nuevos estudios. Uno, la reciente publicación de los resultados del estudio SOUND, y segundo, el estudio prospectivo no randomizado que está iniciando con el objetivo de demostrar que es posible evitar la cirugía mamaria en algunas pacientes que luego de la quimioterapia neoadyuvante presenten radiología y biopsia BAB extendida negativas. Pues bien, representantes de todas estas instituciones forman el núcleo central del programa científico de este curso. Concluyo esta introducción haciendo una mención muy especial a dos grupos de personas que han colaborado para organizar este curso. En primer lugar, al mencionado grupo de docentes que aún desde sus prestigiosas posiciones institucionales han facilitado con ideas propuestas por ellos mismos para estar presentes en este curso y superar las dificultades de todo tipo que se le fueron presentando a nivel profesional, social, familiar y personal. En segundo lugar, al grupo organizador de Tecnoimagen, que con gran esfuerzo, precisión y profesionalidad ha organizado este curso. Año tras año, Tecnoimagen ha logrado convocar a más de 1000 participantes por curso y que este año esperamos superar. A todos ellos, docentes, moderadores, organizadores y a todos los médicos participantes, la Umberto Veronesi Academy y la University of California San Diego expresan su agradecimiento. Paso ahora la palabra a los coordinadores, Karina y Darío, para la continuación del curso.
A presentar la disertación introducción del director del curso, al doctor Paolo Veronesi, no sé si están viendo desde el actual, que es director del programa de Oncología Mamaria del Instituto Europeo de Oncología y director de la División de Cirugía de Mama del Instituto Europeo de Oncología de Milán. Dejo de compartir para que podamos escuchar las palabras del director del curso.
Cari colleghi e cari amici dall'America Latina, vi presento quest'anno per il 4º anno consecutivo il corso online su carcinoma mammario, novità e controversie nel 2023. Quest'anno, a differenza degli scorsi anni, si svolgerà in 2 parti, la prima oggi, sabato, e la seconda sabato prossimo, 28 ottobre. Questo corso, come sempre, è organizzato dalla Umberto Veronesi Academy, con sede a Milano, e dall'University of California di San Diego. Le conferenze online saranno tenute da 13 noti specialisti nel campo della senologia appartenenti alle strutture più all'avanguardia nel mondo per il trattamento del carcinoma della mammella, a partire ovviamente dal nostro Istituto Europeo di Oncologia di Milano, leader in Italia per il trattamento di questa patologia con più di 3000 interventi per tumori della mammella ogni anno, la Spagna con il radiologo Martínez de Vega di Madrid, gli Stati Uniti con l'MD Anderson Cancer Center, con la chirurga Kelly Hunt, 5 specialisti noti in tutto il mondo del Memorial Sloan Kettering di New York e Judy Bugey della Mayo Clinic di Rochester. Quest'anno cresce ancora il numero di partecipanti e saremo più di 1000 collegati da tutta l'America Latina. Gli argomenti, anche questi, saranno di grande interesse e temi di attualità: lo screening radiologico per i pazienti a rischio intermedio, quali sono i criteri per decidere quando fare una biopsia RM guidata, la diagnosi anatomopatologica del tumore metastatico, biopsie solide e biopsie liquide, il trattamento chirurgico o non chirurgico del carcinoma duttale in situ di basso grado, il carcinoma mammario con recettori positivi ER2 negativo, anche qui abbiamo nuovi trattamenti, la possibilità di conservare, grazie a uno strumento fotografico a raggi ultravioletti, i nervi e quindi la sensibilità del capezzolo nella mastettomia nipple sparing, il trattamento del carcinoma mammario con radioterapia e immunoterapia, fino ad arrivare all'utilizzo dell'intelligenza artificiale che si sta diffondendo sempre di più nella radioterapia pratica. Quindi vi auguro di approfittare in profondità di questo nuovo programma di educazione dell'Umberto Veronesi Academy e dell'University of California di San Diego. E voglio ringraziare naturalmente, oltre a tutti voi che partecipate, tutto lo staff di docenti importanti che hanno deciso di dedicare tempo per questa nuova bella iniziativa. Auguri a tutti.
Ya vamos a comenzar entonces. Cari, vamos a compartir la pantalla. Tenemos ya 935 participantes escuchando, así que voy a presentar a la doctora Mónica Fournier, que es la miembro asociada del Breast Medicine Service of Memorial Cancer Center de New York, Estados Unidos, y el moderador de la charla va a ser el doctor Ernesto Gildesa. Doctora Fournier, si quiere compartir pantalla y comenzar su presentación, le agradecemos mucho.
Muchas gracias. Buenos días a todos. Muchas gracias a Gabriel and all the other organizers. I'm going now to switch to English because my Spanish is not good enough for the entire lecture. And we're going to talk about updates in the management of hormone receptor positive and HER2 low or negative breast carcinoma. We're going to talk about some of the updates in early stage disease, and then later on some of the updates in metastatic breast cancer. So this study was presented at ASCO 2023, and it's an adjuvant study of a CDK4/6 inhibitor, ribociclib, plus endocrine therapy as adjuvant treatment in patients with hormone receptor positive and HER2 negative early breast cancer. The study is called NATALEE, and we're going to review the results and the difference with another similar study with a different CDK4/6 inhibitor previously presented, the Monarchy study. So this study enrolled patients with early stage disease, and you can see both node negative and node positive. This is a major difference with the other previously presented randomized study. And they were randomized to endocrine therapy with a non-steroidal aromatase inhibitor, either letrozole or anastrozole, plus or minus ribociclib, the CDK4/6 inhibitor, 400 milligram a day, 3 weeks on, 1 week off, for the length of 3 years. So this is another difference with the Monarchy study. Also, additionally, there was only a non-steroidal aromatase inhibitor allowed, so tamoxifen or toremifene were not allowed in the study. Primary endpoint was invasive disease-free survival, and then recurrence-free survival, distant disease-free, overall survival, and so forth. So just as a little bit of a background for the study, the rationale for enrolling all these patients was basically to include also patients with node-negative disease, as we have seen, and lower risk of disease that, however, might still have a significant risk of developing metastatic breast cancer in the future. The rationale for basically 400 milligram of ribociclib instead of 600 was to improve tolerability while maintaining the efficacy, and also 3 years duration. That's a very long time, as opposed even to the 2 years of the Monarchy study, but the rationale behind it was to extend the duration to prolong cell cycle arrest and basically try to improve outcome by driving more cells into irreversible senescence. Don't seem to be able to advance. Okay, so these are the baseline characteristics of the patient. As I mentioned previously, the median age, fairly standard, around 52 years, but there were not only node-positive patients like in the prior study, but also a significant amount, about 30% of node-negative patients were enrolled. This is the patient disposition when this data was presented. About 70–80% of patients still were undergoing treatment with ribociclib plus non-steroidal aromatase inhibitor or aromatase inhibitor alone. There were also some patients that had completed the treatment, and also there was a proportion of patients that had discontinued treatment with primary reason, of course, for adverse events in this patient group. And here you can see some of the causes of death as well, and some of the side effects. Primary endpoint, this was a significantly positive study. This is the second interim efficacy analysis of invasive disease-free survival, and you can see NATALEE met its primary endpoint with ribociclib plus aromatase inhibitor, significantly improving invasive disease-free survival versus aromatase inhibitor alone. And this improvement was consistent across all different pre-specified patient subgroups. Here you can see that the benefit was consistent throughout patients with stage 2, stage 3 disease, prior chemotherapy, their neoadjuvant or adjuvant, nodal status, node negative or node positive, although the node negative group crosses 1 in the hazard ratio because likely of the small number of patients. When we're looking at the distant disease-free survival, there was a benefit which was maintained again with a significant P. So basically the benefit was increased with the combination of ribociclib plus aromatase inhibitor as opposed to aromatase inhibitor alone. Survival-wise, there was a non-significant trend towards improved overall survival with the combination. However, we will need further follow-up. In terms of safety, you can see some of the side effects that we already know for ribociclib as opposed to other CDK4/6 inhibitors, such as neutropenia, febrile neutropenia, QT interval prolongation, which is specific of this particular drug, and also arthralgia, myalgia, and mostly derived from aromatase inhibitor. Most common adverse event leading to discontinuation were liver related and increase in the QTc interval. When we're looking at the lower dose of 400 milligram versus 600, which is the currently FDA approved standard dosing, you see that 400 is much better tolerated with less side effects, including QT prolongation. So that's the reason why this dosing schedule was chosen also in the consideration of the length, 3 years of the treatment. So in conclusion, NATALEE met its primary endpoint of improvement in invasive disease-free survival, and the improvement was consistent across pre-specified patient subgroup. Distant disease-free and overall survival were also improved with a combination, although overall survival was not statistically significant at this time, but we'll see with longer follow-up. The benefit for now in stage 2 node-negative patients remains unclear, and this is kind of early data because only 20% of patients completed 3 years. And what we do know is 400 is better tolerated than the 600 schedule. This is the data comparing the presented study with the abemaciclib monarchy trial. You see that the benefit is very similar in disease-free survival. There was a significant reduction in risk of developing an event. When we're looking at the toxicity, you see that neutropenia was similar for the two agents, comparing ribociclib and abemaciclib. There was some liver toxicity as well. QT prolongation was present with ribociclib, but not with abemaciclib, while diarrhea instead was much more frequent with abemaciclib as opposed to ribociclib. So consistent to what we know from the metastatic setting. So what are the implications of the study, basically? There was a 25% risk reduction, which is clinically meaningful. The absolute benefit is around 3%, which is modest, but again, the data is still early, and there's only 20% of patients that have completed the 3 years of therapy. We don't know if the benefit will persist over time, but in the monarchy study, the benefit seemed to actually increase over time. And so it's likely that in the study as well, the benefit will remain. It can only be given with aromatase inhibitor. This study was not done with tamoxifen or with toremifene, also because there is an increased risk of QT prolongation with these agents. And so if patient came off the study, they had to discontinue ribociclib with tamoxifen. They could not continue with ribociclib with tamoxifen. They had to go to single agent tamoxifen. One must weigh, of course, the benefits versus the risk of the 3 year of therapy. It's a very long time for side effects and for patient compliance as well. For the time being, given the follow-up in the longer follow-up in the Monarchy study, abemaciclib should likely be the standard for high-risk hormone receptor-positive early-stage disease. We can consider ribociclib in patients with high risk who missed, however, the Monarchy eligibility, and could also be an option for those patients that are intolerant of abemaciclib. Remaining questions is the optimal patient selection. So what about the benefit of patients with node-negative disease? Is 3 years really necessary? And also, of course, benefit-risk ratio worth the adverse events and also the financial toxicity. Taking a look now at the Monarchy study that we mentioned, some data was presented at ASCO regarding the benefit of patients with older age. And here you see the schema of the study, very similar to the prior one, except tamoxifen was also allowed in the study, not only aromatase inhibitors, so patients were randomized to either abemaciclib plus endocrine therapy versus endocrine therapy alone, and treatment was only 2 years as opposed to 3. As I mentioned, the benefit in terms of invasive disease-free survival, distant relapse-free survival, seems to persist in time. Here you can see it seems actually to become deeper and to be maintained over time after completion of the 2-year treatment period. Older patients actually derive similar benefit from abemaciclib in the intent to treat patient population. As you can see here, they were divided less than 65 and over age of 65 and above. And again, the benefit seemed to be maintained for the subgroup of patients as well. Absolute benefit was very similar. This is important because of the aging population, of course. Adverse events rates were similar between patient group less than 65 years of age and more than 65. However, there was a higher incidence of side effects as can be expected, and with dose adjustments as well as discontinuation were more frequent for patients 65 and older as opposed to younger patients. What is important to note, however, that even though older patients tended to have more dose adjustment than younger patients, the dose adjustment resulted in a lower relative dose intensity, and this was explored. And basically, it was great to see that although they were taking a lower dose, the benefit was maintained. So even if we have to dose reduce our patient, we can tell them that the benefit in terms of risk reduction will be maintained. And it was consistent from the lower patients with the lower dose intensity to the highest. So in conclusion, the benefit of adjuvant abemaciclib plus endocrine therapy is consistent across different age groups. Adverse event rates were similar. However, treatment discontinuation were greater in older patients. At the same time, invasive disease-free survival was similar between the different RDI categories, meaning patients that had the liver that had less agents were on lower dosing. So the big question is whether we should start our older patient on a lower dose to begin with, for example, at 100 milligram twice a day of abemaciclib rather than the full dose. Switching now to metastatic breast cancer, we're going to touch on endocrine therapy and antibody drug conjugates. So this is the approach to therapy currently for patients with hormone receptor positive and HER2 negative metastatic breast cancer. We see like a number of endocrine therapy or endocrine plus with a number of other agents in the first, second, third line. Then we can switch to chemotherapies, pembrolizumab. In selected cases, patients can also be treated with alpelisib if their disease harbors a PIK3CA mutation. Of course, if they have BRCA1 or 2 mutation, then olaparib or talazoparib would be options. Now we have elacestrant for patients with disease with a ESR1 mutation. and then antibody-drug conjugates such as sacituzumab govitecan and trastuzumab deruxtecan in later lines, and these are also investigational. We have capivasertib and neratinib for HER2 mutant and so forth, but we're going to focus now with the most recent data. This is what I think was a very interesting study. It's a Dutch study. It's a phase 3 study assessing the optimal position of CDK4/6 inhibitors for patients with metastatic disease. So we generally start patient first line with endocrine therapy plus a CDK4/6 inhibitor. But the authors wanted to see whether you can postpone this to second line. And so they wanted to evaluate the efficacy of CDK4/6 inhibitor added to either first line or second line therapy for patients with metastatic disease. So patients were randomized, patients with stage 4 HER2 positive, hormone receptor positive, HER2 negative metastatic breast cancer. They were randomized to either a non-steroidal aromatase inhibitor plus CDK4/6 inhibitor, or just a non-steroidal aromatase inhibitor, switching then to fulvestrant plus a CDK4/6 inhibitor at progression of disease, with two endpoints, primary endpoints primary endpoint of progression-free survival number 2, meaning time from randomization to second disease progression or death. And then, of course, secondary endpoints of overall survival, quality of life, and so forth. About 1,000 patients were randomized. And you can see, as expected, the first progression-free survival, of course, was superior for aromatase inhibitor plus CDK4/6 inhibitor, as expected, in comparison to patients with aromatase inhibitor only. However, the second progression-free survival, which was the primary endpoint of the study, was indeed exactly the same, showing that the benefit was somehow recuperated when second-line CDK4/6 inhibitor was introduced. Overall survival was very similar between the two arms and seemingly did not show a benefit for giving CDK4/6 inhibitors either in first or in second line. So I think this is very important data, because it shows that there is no specific benefit in adding the CDK4/6 inhibitor in first line as opposed to second. So you can choose to add it in second line as well. So the addition of first line, of course, prolongs times on CDK4/6 inhibitor and increased toxicity. The author suggested that although you can keep using first line endocrine monotherapy, in their opinion, second line use of CDK4/6 inhibitor can be preferred. Switching now to two other trials that assessed the use of fulvestrant plus CDK4/6 inhibitor in second line. One of the big questions is whether to continue with CDK4/6 inhibitor at progression or not. So two trials, the MANTAIN study, basically patients progressing on endocrine therapy plus palbociclib, plus a CDK4/6 inhibitor. 87% had received prior palbociclib. They were randomized to switching endocrine therapy and continuing a CDK4/6 inhibitor, or simply continuing a second-line endocrine therapy. And when they switched, the switch was ribociclib. So because 87% of patients received prior palbociclib, there was a change in the CDK4/6 inhibitor. And this study actually revealed the benefit in continuing the CDK4/6 inhibitor, which actually seemed to be particularly for patients with ESR1 wild type, as opposed to patients who had a mutation of ESR1. At the same time, there was another study, the phase 2 PACE study, which instead the patients were randomized to switching endocrine therapy, but continuing palbociclib. And this study, because again, 90% of patients had received prior palbociclib, so there was overall no change in the CDK4/6 inhibitor. And this study at the same time did not reveal a benefit for continuing palbociclib. What we can derive, these were two studies with kind of different results. However, in the first study, there was a switch from one CDK4/6 inhibitor to the other, while in the second study, most patients were on palbociclib and remained on palbociclib. So it's possible that there is a benefit when you switch from one agent to the other. Targeting ESR1 mutations with selective estrogen receptor degrader. It's important because ESR1 mutation is a very well-known mechanism of resistance to endocrine therapy. Fulvestrant is a third selective estrogen receptor degrader. However, its efficacy can be limited by poor availability. So oral agents have been studied because they have greater availability and activity in the setting of endocrine resistant. Elacestrant has been recently FDA approved. It did show in vitro and in vivo anti-tumor activity, and then it proved benefit in a large phase 3 clinical trial. This was the phase 3 Emerald trial for patients with metastatic breast carcinoma who had progressed or relapsed after 1 or 2 lines of endocrine therapy, one of which had to be given in combination with a CDK4/6 inhibitor. Patients were randomized to either elacestrant 400 milligram daily or one endocrine therapy of investigator choice. Primary endpoint, progression-free survival in all patients, and progression-free survival in patients with ESR1 mutation. Just to remind you, ESR1 mutation are usually not present at first diagnosis, but rather they are developed under the pressure of prior endocrine therapy. So it's very important to test for this mutation at every single progression of disease. This study was a positive study. There was a benefit in progression-free survival for elacestrant versus standard of care, physician choice of endocrine therapy. And this you can see in particular versus any endocrine therapy and versus versus fulvestrant. In patients with a ESR1 mutation, the benefit was even more pronounced. There was a difference, a delta of 2.8 months in median progression-free survival, which was both for patients for patients with any endocrine therapy versus elacestrant, or for patients treated with fulvestrant versus elacestrant. This study led to the FDA approval of elacestrant for patients with ESR1 mutation. I should say for patients with disease with the ESR1 mutation. This agent is fairly well tolerated, some GI side effects, but overall well tolerated. Grade 3 and 4 were limited to nausea, fatigue, vomiting, and all the rest was basically of lower grades. Switching now to an antibody-drug conjugates, since this is basically a new class, we're going to briefly review sacituzumab govitecan, which is an antibody-drug conjugate versus the TROP2, which is an antigen expressed in many epithelial cancers, including breast cancer. This agent was first approved for patients with triple-negative breast cancer and now has a second approval for patients with hormone receptor-positive, HER2-negative breast cancer. This is the study that led to the approval for patients with hormone receptor-positive, TROPiCS-2, patients with previously treated metastatic breast cancer with chemotherapy as well as CDK4/6 inhibitor in any setting, and 2 to 4 prior lines of chemotherapy for metastatic breast cancer. So a heavily pretreated patient population were randomized to physician choice of treatment. And you can see the choices: capecitabine, vinorelbine, gemcitabine, or eribulin, or sacituzumab govitecan, again, which is an antibody-drug conjugate. This idea, I always like to say, this idea of the antibody-drug conjugate is not new. Back in the 1800s, I think, one physician, the name escapes me, had this idea that regarding antibiotics, that if you could create a shuttle carrying a drug only to the sick cells, so to speak, a lot of toxicity would be spared. Of course, it took over 100 years and a lot of knowledge to put this idea into place. But these agents are basically a monoclonal antibody with a linker that carries molecules of chemotherapy. So this study was a positive study for a benefit of sacituzumab govitecan over treatment of physician choice with a significant improvement in progression-free survival. Overall survival, there was also a benefit from this trial. And as a matter of fact, the benefit was consistent independently of TROP2 expression level. So you do not need to check the expression level because the benefit appeared throughout. Side effects were pretty much similar to prior trials, including some hematologic side effects, but mostly gastrointestinal, including diarrhea, nausea, and so forth. Diarrhea was the most frequent side effect, and that's because of the chemotherapy SN38, which is bound to the monoclonal antibody, which is an agent similar to irinotecan. So basically, this study, which was updated at ASCO 2023, shows that there was a significant reduction in risk of progression or death for patients treated with sacituzumab govitecan, a 21% reduction in risk of deaths, benefit observed regardless of TROP2 or HER2 expression level. So again, this is a very good option for patients with hormone receptor positive breast cancer. And the second antibody drug conjugate that we're going to review is trastuzumab deruxtecan, which you're probably very familiar with. Again, similar mechanism of action, an antibody, a linker, and then a molecule of chemotherapy. This is a highly potent topoisomerase 1 that it's linked, and therefore this compound can bind to the receptor, specifically the HER2 receptor, in this case, can get internalized, and the chemotherapy agent can be released and induce apoptosis in the cells. There's also a bystander effect, meaning that the release of the drug payload before internalization can lead apoptosis into surrounding cancer cells. This was the phase 3 DESTINY-4 clinical trial. Again, patients with HER2 low, IHC 1+ versus IHC 2+ FISH negative. They were randomized to either standard chemotherapy versus trastuzumab deruxtecan. This was a very important study because, of course, given that HER2 is the target, it was initially limited to patients with HER2 overexpressing disease. However, as we probably all know, HER2 is not a kind of binary receptor, meaning there's not only HER2 positive and HER2 negative, but we should say HER2 overexpressing and HER2 low, because there are still some HER2 overexpressing receptors even in breast cancer cells that are defined as HER2 low, such as IHC of 1+ or IHC of 2+ FISH negative. Primary endpoint was progression-free survival. And as you probably know, this data was presented at ASCO 2022. Benefit was kind of striking, with a benefit in progression-free survival as well as in overall survival for trastuzumab deruxtecan in patients with hormone receptor positive and HER2 low. So not HER2 positive, but rather HER2 low metastatic breast cancer. And this has led to approval of this drug in this setting. Treatment-related side effects, many of these were expected. Unfortunately, this agent has an incidence of interstitial lung disease and pneumonitis, and that can be fatal in certain cases, and so you have to check with serial CT scans. Other than that, most common side effects were nausea, fatigue, and neutropenia. So again, this is the summary that I showed before. We have now a number of new agents in the treatment for metastatic breast cancer, and more are coming on the horizon. So hopefully we'll be able to maintain these patients with fairly good quality of life for longer and longer, and increase their survival. And this is my last slide. Thank you so much for listening, and I welcome preguntas. Thank you.
Thank you, Dr. Fournier. Dr. Gildesa, if you want.
Muchísimas gracias por la presentación. Excelente. Me voy a centrar exclusivamente en los tumores luminales ER2 negativos. Y me parece que hay dos tópicos que valen la pena resaltar. Uno es el impacto del SONIA Trial, que en avanzados me parece que es muy interesante que lo hayas marcado, porque es un ejemplo de una investigación sin conflictos de intereses y llevadas a cabo en hospitales públicos, y que creo que plantea con absoluta claridad el hecho de que los anti-CDK 4/6 en primera línea no ofrecen ventajas en términos de sobrevida ni de calidad de vida. Entonces, mi primera pregunta es, ¿esto ha cambiado tu aproximación con los pacientes?
Thank you. This is a great question, and I wish I could answer in Spanish, but I'll answer in Italian. Yes, that is the reason why I showed that study, because it's a Dutch study actually, and I think it is very interesting because we're all used to use CDK4/6 inhibitor from the beginning, but this data tells us that we can safely wait and reuse it and second line, and that the benefit will be maintained and recuperated. So regarding your question as to whether it has changed my practice, I have to say that even before the SONIA study, I tended sometimes in selected patients, for example, older patient that sometimes didn't want to take the additional pill or didn't want to come to the hospital for frequent blood work, that had maybe minimal disease, such as, bone-only lymph nodes, I would tend to start them on endocrine therapy only, and then at progression in second line, add the CDK4/6 inhibitor. Of course, younger patient with more aggressive disease, maybe also visceral involvement, I would still tend to start the CDK4/6 inhibitor at the beginning and first line. Those are the patients that I would be interested in having, a quick, faster response and earlier on rather than at progression. But, in selected patients, like older patient with, mostly bone-only disease or lymph nodes or chest wall, I would by all means delay to second line.
Muchas gracias.
De nada, sí.
La segunda pregunta está centrado en el rol en adyuvancia, en el NATALEE y en el Monarch E. Un punto crucial es que el 90% de estos pacientes recibieron quimioterapia previa. 9 de cada 10 enfermos en ambos ensayos hicieron quimioterapia previa. Y la pregunta es si lo que estamos viendo podría ser o estar relacionado con el tipo de quimioterapia que recibieron los pacientes previamente, porque no vi que estuvieran estratificados por el tipo de quimioterapia. La segunda pregunta en esa misma línea es si te satisface la Invasion Disease Free Survival como meta de evaluación, y si sabes si hay alguna correlación con Overall Survival. Y el tercer punto es la toxicidad financiera, porque costaría $15 millones evitar una Invasive Disease Free Survival. Entonces, estas tres preguntas sobre este tópico.
So regarding the choice of chemotherapy, I mean, yes, you're correct. But, most of these patients, because they had high-risk disease, I mean, there were some node negatives, but most of these patients had high-risk disease. They received chemotherapy, including an anthracycline and a taxane combination regimen. So I hear you. There could have been a difference maybe between one regimen and the other, but the assumption is that, all this regimen kind of, we had in the past comparison between one regimen and the other. Many of them are kind of similar. So the assumption is that the benefit given by chemotherapy was somewhat similar, even if the regimen were slightly different. Some, I don't know, in the US, especially on the East Coast, we use a lot of AC followed by paclitaxel. Epirubicin is more utilized in Europe and in Canada. TC, docetaxel, cyclophosphamide is also used. So, I mean, I think the assumption was that, there was a X amount of benefit delivered by chemotherapy. Regarding your second question was tell me your second question again about
Y si estás conforme con la invasion diffuse.
right. I forget with the invasive. Yes, I mean, yes, I am happy because I think that, you know, what we are trying to look in these studies is that not having patients recur, not so much as the survival. The benefit can take years because now we have many drugs that can improve the survival of metastatic patients. So a survival benefit can take many years to be seen. However, what we want is for this patient not to recur with metastatic breast cancer. So I think, yes, that is a good point. At the same time, I agree with you 100%. 3 years of therapy is a very long therapy for a number of reasons, for compliance, for toxicity, and also, as you say, for financial toxicity. So I think for now we should stick with 2, and then I don't know, we'll see what happens. In a way, you know, you're kind of treating subclinical metastatic breast cancer in a way, right? Because you're giving active therapy.
Ok, Ernesto.
Muchas gracias.
Muchísimas gracias. Gracias, Ernesto. Gracias, doctora Fournier. Y continuamos con el programa. Cari.
Sí, perfecto, Darío. Ahí estoy compartiendo
¿Está muteada, Carini?
pantalla. No. Estoy, ahí está. Me está escuchando, estoy tratando de compartir la diapositiva, no sé si la están viendo completa. Vamos a dar paso al próximo conferencista. Quiero invitar al doctor Alberto Rancati, que es director de la División de Cirugía Oncoplástica de la Universidad de Buenos Aires, Argentina. Es profesor asociado de la Universidad de San Diego, de Estados Unidos. El doctor Alberto Rancati también es director de la Umberto Veronesi Academy y es vicepresidente de la Fundación FASEC, Fundación Argentina contra el Cáncer. Alberto, te damos la bienvenida. Va a moderar su presentación el doctor Yazan Manzanat. Bienvenido, Alberto.
Gracias, Karina. Ok, bueno, buenos días a todos. Gracias, Gabriel, Paolo, Darío y Karina por la organización de este curso. En esta sesión que va a estar moderada por el doctor Yazan Manzanat de Escocia, vamos a tratar de hablar sobre la nipple sparing conservar la sensibilidad de la mama. O sea, todos sabemos que desde que empezamos con las nipple sparing mastectomy, las ventajas estéticas para la paciente son enormes y una de las quejas más frecuentes es la falta de sensibilidad de la mama. Entonces, la intención y el mensaje para esta presentación es darles algunos tips anatómicos en cirugía oncoplástica mamaria, sobre todo en nipple sparing mastectomy, porque la sensibilidad depende básicamente de la preservación de estructuras que ya existen y que algunas tienen que sacrificarse durante la mastectomía en función del tratamiento de la enfermedad y hay otras que pueden preservarse. Hasta ahora todo lo que hay sobre preservación de la sensibilidad o restablecimiento de la sensibilidad es la reconexión microquirúrgica de los nervios para volver a lograr algo de sensibilidad en el complejo areolar pezón. Pero les voy a mostrar algunos estudios interesantes sobre de qué manera se puede preservar la sensibilidad en la mama después de la nipple sparing mastectomy. Para eso necesitamos identificar cuáles son los pedículos neurovasculares. Sabemos que cuando hacemos una nipple sparing mastectomy tenemos que sacrificar muchos pedículos vasculares y por eso una de las principales complicaciones en esta práctica es la isquemia y la necrosis después de la nipple sparing. Bueno, no solamente los pedículos tienen vasos, arterias y venas, sino también que algunos tienen nervios que hasta ahora eran muy difíciles de identificar porque los nervios sensitivos son muy finos como para verlos con la luz de la cialítica. Entonces, voy a tratar de mostrarles alguna evidencia que hay sobre la posibilidad de preservar estos pedículos. Según la Sociedad Americana de Cirugía Plástica, más de 100.000 mujeres sufren una mastectomía todo año y una de las mayores quejas es la falta de sensibilidad. Pero esto es posible en algunos casos de preservar la sensibilidad después de la nipple sparing. Para eso tenemos que volver a lo básico, a la anatomía. Hoy con la fluorescencia tenemos la posibilidad de identificar pedículos vasculares y neurológicos. La fluorescencia no es solamente el ICG, el verde indocianina, que trabaja, como ustedes saben, con una longitud de onda cercana a la infrarroja, con lo cual colocando verde indocianina uno puede identificar los vasos, sino que también existe ahora una cámara que con emisión de luz cercana a la ultravioleta podemos, sin colocar ningún compound endovenoso al paciente, como se necesita para el ICG, solamente con un juego de filtros y luces podemos ver fluorecer los nervios. Entonces la identificación dentro del acto operatorio de los nervios es lo que nos va a permitir mantener la sensibilidad. Eso nos va a permitir también colocar la incisión en el lugar correcto para no cortar estos nervios, hacer una resección tumoral segura y tener menos complicaciones vasculares y nerviosas después de la nipple sparing mastectomy. Esto es algo que los cirujanos vemos frecuentemente después de las nipple sparing mastectomy, que es este patrón de isquemia y de necrosis, dos pacientes distintas, en esta zona central. Y si ustedes ven la incisión, es una incisión generosa en el surco mamario, en donde cortamos todos los pedículos perimamarios inferiores. Y especialmente esta zona central que involucra el complejo es por la sección de la quinta intercostal, el ICAP, Anterior Intercostal Artery Perforator. Este pedículo es muy importante, más de lo que teníamos pensado. Para eso hicimos 23 cadáveres, disección de 23 cadáveres, inyectando con látex de color la arteria mamaria interna, ligando abajo la epigástrica, para que el látex se distribuyera en todas las intercostales. Y acá vemos, como si estuviéramos disecando en una skin reducing mastectomy, colgajo, y este es el surco mamario aquí abajo, vemos este pedículo teñido de negro que llega hasta el complejo areola-pezón, que es la quinta intercostal. Este vaso, que empezamos a preservarlo por una cuestión de seguridad vascular para no tener isquemia en el complejo y en esa zona central, acá lo ven en una foto invertida, acá es el origen del quinto intercostal y acá llega hasta arriba corriendo en la grasa y siempre está en ese plano, porque embriológicamente es así, entre la piel y la glándula. O sea, esa grasa que está entre la piel y la glándula, que ya describimos que hay 3 tipos, 1, 2 y 3, entre menos de 1 centímetro, entre 1 y 2 centímetros y más de 2 centímetros, es muy fácil de ver en una mamografía digital o en una resonancia, y entonces esa grasa que nosotros vemos en el surco mamario, rodeando la glándula y arriba en el polo superior, nos va a hablar de la categorización de pacientes. Los que más grasa tienen es donde más espacio tenemos para poder preservar estos pedículos. Obviamente, en las pacientes que tienen la piel pegada a la glándula y casi no tienen tejido graso, es mucho más difícil preservarlo. Pero siempre está ahí, hora 6 en el surco mamario. Entonces, la evidencia de esto en las disecciones, lo que vimos es que había una descripción de Boehringer sobre cómo es la fascia de Boehringer, en donde transcurre la cuarta intercostal, y estaba descripta que la quinta intercostal también entraba en la fascia de Boehringer. Así fue descripto esto. Después de este estudio de cadáveres, y fue publicado esto en marzo de este año, observamos que la quinta intercostal no entra en la fascia de Boehringer, sino que rodea el polo inferior de la glándula, llegando con vasos directos hasta el complejo areola-pezón. Entonces, esta zona de conflicto, cuando uno hace una incisión en hora 6 en el surco mamario, secciona invariablemente la quinta intercostal. Y es uno de los vasos principales porque cuando uno hace la nipple sparing mastectomy y diseca el disco mamario de la aponeurosis del pectoral, lo que queda remanente de vascularización es la segunda intercostal, la tercera y la cuarta están dentro del disco, con lo cual hay que cortarla, y la quinta que transcurre aquí. Ahora, si nosotros cortamos este pedículo neurovascular en hora 6, vamos a no solamente disminuir el aporte sanguíneo al complejo areola-pezón, sino también la posibilidad de mantener la sensibilidad. Entonces, este punto de hora 6 en el surco mamario, en donde está el meridiano de la mama, es muy importante preservarlo. Publicamos esto con el doctor Navidian, el doctor Angrillani, el doctor Irigo, haciendo los 23 cadáveres, y entonces esta es la red nerviosa, los nervios supraclaviculares, los cutáneos laterales y las ramas, estas que vienen de las intercostales, y esta zona de conflicto es la que tenemos que preservar para tener estos nervios que sigan funcionando y podamos mantener sensibilidad en la zona del complejo areola-pezón. Acá vemos una visión lateral, cómo está descrito hasta ahora, o sea, la restoration de la sensibilidad con nervios que se reconectan como injertos directamente desde donde está la quinta intercostal hasta el complejo, y estos nervios pueden ser preservados en vez de cortados y después hacer un injerto, sabiendo dónde están. Entonces, este pedículo en hora 5 es un pedículo neurovascular muy importante que hasta ahora no sabíamos. Entonces, esta es una de las del mapeo de la vascularización de la mama. Segunda intercostal, que vemos que sale fuera del disco mamario. Tercera, cuarta y la quinta, que detrás de la costilla larga estos ramos, el MICAP, Middle Intercostal Artery Perforator. Acá en hora 6, el Anterior Intercostal Artery Perforator, y el lateral, que es el LICAP, el Lateral Intercostal. También tenemos la vascularización que viene de la torácica lateral, rama del axilar, y todas estas de la mamaria. Y también algunos ramos que vienen de la subclavia, atravesando el músculo pectoral. Entonces, esta es la línea en el meridiano, hora 6, y aquí es donde sale este pedículo tan importante neurovascular. Entonces, moviendo la incisión de hora 6 a lateral, solamente haciendo esta maniobra, nosotros, si preservamos la grasa, podemos preservar este pedículo que nos va a ayudar vascularmente a tener menos complicaciones isquémicas y, desde el punto de vista sensitivo, a mantener la sensibilidad. Acá vemos una demostración, movámonos un poco a qué es lo que pasa en la reducción mamaria para entender por qué pasa esto en las nipple sparing mastectomy. Esta es una paciente, como ven, para una reducción mamaria marcada para un pedículo inferior. Entonces, la marcación, vamos a ir rápido para no perder tiempo, marcamos el complejo y acá vemos cómo cortamos y tenemos solamente la vascularización de ese complejo desde el pedículo inferior, ¿sí? O sea, no hay posibilidad de que venga otra sensibilidad que esa del pedículo inferior que estamos hablando. ¿Por qué? Porque está mantenido el ICAP, este pedículo, ahí abajo. Cuando fue descrita esta técnica, nadie pensaba en los vasos que permitían esto, sino que era una descripción topográfica, pedículo inferior, pedículo superior, pedículo central. El pedículo es el vaso que lo mantiene vivo a ese pedículo, y ese pedículo, en este caso, inferior, es el ICAP. Entonces, el pedículo inferior es un pedículo ICAP. Entonces, acá vemos cómo solamente con un pedículo, el inferior, podemos cortar la dermis, no pasa nada, porque el pedículo viene póstero inferior, el ICAP nace de la aponeurosis ahí atrás, y vemos entonces cómo queda, y acá vemos la demostración, cómo mantiene la sensibilidad la paciente solamente con un pedículo, con el pedículo inferior en el borde de la areola y en el complejo areola-pezón, ahí lo ven. Entonces, esta es la certeza, la demostración de que un pedículo solamente puede mantener la sensibilidad. Acá vemos cómo está marcado un pedículo inferior, que es el tejido que solamente va a mantenerse, y cómo fue descrito por Leacir Ribeiro, este tipo de pedículo, en donde él no sabía que estaba el ICAP ahí abajo, porque estos son estudios posteriores, esto es de los años 70. Bueno, hoy sabemos que lo que mantiene la vascularización, la vitalidad y la sensibilidad es el ICAP, el Anterior Intercostal Artery Perforator, que está en hora 6 y es un pedículo neurovascular. Había ya varios estudios anatómicos que fueron pasados por alto, donde la sensibilidad con las diferentes técnicas, la mejor sensibilidad del complejo se mantenía en las reducciones mamarias con el pedículo inferior. De vuelta, una evidencia de que el ICAP tiene esa potencia de mantener vascularización y sensibilidad. Y también otro estudio de Cerletti sobre long-term satisfaction después de la reducción mamaria con el pedículo inferior. O sea, todo esto fue publicado y pasado por alto, y hoy sabemos por qué es que ocurre esto. Entonces acá vemos también en una reducción mamaria a pedículo inferior, y cuando hicimos un pedículo superior, como en este caso, tuvimos la posibilidad de utilizar una nueva cámara, que es esta cámara que estamos investigando de luz ultravioleta, que se llama Dendrite cámara, ahí la ven, y disecando el ICAP podemos ver cómo la visión, la de arriba es con la cámara, y ven cómo aparece el nervio en el pedículo, en el ICAP, esto fluorescente ahí blanquecino es el nervio, y con la luz abajo de la cialítica, nada, es un vaso más, como cualquier otro. Entonces, la importancia, como ven, de saber que esto tiene un nervio que acompaña y que nos da sensibilidad al complejo, y por eso la importancia de mantenerlo. Solamente moviendo la incisión 4 centímetros a la izquierda, dejando la línea media, podemos preservar este pedículo. Entonces, esta es la cámara con la que estamos trabajando, dendritemaging.com. Hay 3 prototipos en el mundo en este momento. Estamos haciendo un convenio con la Umberto Veronesi Academy para dejarles una cámara. La empresa les va a dejar una cámara en el instituto porque sirve no solamente para mamas, sino también para todo lo que uno necesite ver de nervios, ¿no? En cirugía tiroidea para ver los recurrentes en el abdomen genital, en vaciamientos de cuello. Entonces, la posibilidad de poder ver los nervios nos dio la posibilidad de investigar y mover las incisiones y preservarlos, como para poder mantener la sensibilidad. Acá vemos un ejemplo de nervios recurrentes, como se ven, que son muy difíciles de ver en una tiroidectomía, o el nervio abdominogenital en una hernioplastia, que es una de las lesiones más frecuentes que se producen y da una anestesia en la zona de la hernia. Entonces, hoy viendo esta posibilidad, nos da un potencial para adelante en donde vamos a seguir descubriendo nuevas cosas, y nos da la posibilidad de mejorar la calidad de vida de nuestros pacientes. La cámara ya tiene los papeles dentro de la FDA y la patente, por lo que nos dice la gente de Dendrite, y a fin de año parece que está lista. Acá vemos entonces un caso en una nipple sparing mastectomy. Esta es la marcación que hacemos siempre: línea media, meridianos, segunda intercostal, marcación del disco mamario, tercera, cuarta, que son las que se cortan invariablemente, MICAP, ICAP, LICAP, incisión planteada en este caso en el surco mamario lateral, a veces puede ser una S itálica acá arriba, y entonces de esta manera empezamos a buscar en este paciente que tenía más de 2 centímetros de grasa de cobertura, un tipo 3, y acá vemos con la cámara la misma imagen en donde se ve esto fluorescente acá, que son los nervios. Entonces, esto es una paciente que era una paciente BRCA positiva, una mastectomía con reconstrucción prepectoral, y acá vemos el resultado, habiendo preservado.
¿Sí?
Sí.
Ahí.
Sí.
Ahí. ¿Sentís? Muy bien. ¿Ahí sentís?
Sí. Ay. Ay, Daisy.
Sí.
Ok, entonces esta posibilidad, este seguimiento de la paciente a 3 meses.
Ahí.
Sí.
Ahí.
Sí.
Ahí.
Sí.
Ahí.
Sí.
Ahí.
Ok, entonces esta posibilidad que nos da
Ahí.
la preservación del pedículo, lo publicamos en el PRS hace 2 meses, cómo identificar y preservar el quinto intercostal en nipple sparing mastectomy. Creemos que es un avance importante dentro de lo que es mastectomías conservadoras, y que entonces hoy podemos encontrar casos en donde podemos ofrecer esta tecnología. Esta es la cámara, cómo es que se utiliza. Se ve en una pantalla, como vemos sobre la derecha. Entonces uno ve los pedículos nerviosos fluorescentes. Esto también sirve mucho en microcirugía, y en pacientes que tienen traumatismo, en trauma. Pensamos que en prostatectomías, o sea, toda la posibilidad que dé esto de ver los nervios va a cambiar el juego en cirugía. Acabamos de presentar también esto en el Aesthetic Surgery Journal sobre aumento mamario, o sea, cambiando la incisión tradicional del aumento mamario en hora 6 en el surco mamario lateral, preservando el ICAP. Tuvimos una diferencia muy grande sobre la sensibilidad, evaluando antes y después a la paciente en aumento mamario, solamente por preservarle el quinto intercostal. O sea, normalmente en un aumento mamario muchos pacientes refieren tener adormecimiento del polo inferior de la mama. Bueno, cambiando la incisión a hacerla 3 centímetros lateral en el surco mamario y preservando el ICAP, eso se eliminó. Con lo cual, como mensaje final, creo que es muy importante que sepamos que en el surco mamario en hora 6 existe un elemento que hasta ahora no sabíamos, que es el ICAP, y que es un pedículo neurovascular, con lo cual deberíamos evitar en lo posible, cuando oncológicamente es permitido, evitar incidir sobre la hora 6 del surco mamario para preservar el ICAP nerve. Muchas gracias.
That's perfect. I think this is an important talk because we started with radical mastectomy years ago. Then we moved to conservative mastectomies, doing skin sparing mastectomy. Then we pushed the boundary, looking at nipple sparing mastectomy. But this will pave the way to what we call functional reconstruction, because we are not only giving a breast mount, we're giving a breast mount that will have a bit of sensation with it, which is great way of pushing the boundaries. I have a question for Alberto before we look at the questions that are online, because many of them are written in Spanish, so apologies, I really cannot read them. Now, Alberto, the camera is beautiful and it shows beautifully the nerves, but how essential is the camera? If you just move your incision 4 centimeters laterally, will that do the job? Or will the camera sometimes add much? Will it show you some other nerves that you want to preserve?
Yes, wonderful question, because we are not using now the camera in every patient, because we know that the nerve is there. We have made cadavers. We had made several studies in breast reduction, breast augmentation, nipple sparing mastectomies, and the nerve is always there. So just to know that the nerve is there, if you don't have the camera, but you move the incision, you can obtain the same results. I think the camera will be wonderful for new investigations, because perhaps we can preserve the lateral nerves and also for different operations like prostatectomies, trauma, thyroidectomy. So I think it will be a new weapon for all of us as surgeons. But regarding the breast, as you say, now we don't use the camera in every nipple sparing mastectomy because we avoid looking at the nerve just to avoid any accident. So we know it is there, and the results are consistent. So we are obtaining very good results in terms of sensation after preserving the ICAP.
And I'm really sorry for people that are putting questions on the Q&A section because I cannot really read Spanish or Portuguese, so sorry for that. Alberto, if you do a Doppler and you find where your ICAP is that always where the nerve is, or can it be variable?
Yeah, no, it's always there. So the anatomy is like, if you know that the carotid are here and the aortic is here, the ICAP is always there, the LICAP is always there, the MICAP is always there. So the vascularization for the breast is always the same. And I think that what you are asking is one of the main problems why we still have some ischemic complications. It's because we don't know how the vascularization of the breast is. So with the Doppler, you can check it in every case, and you will find that they are always the same vessels at the same position.
And if you notice, most of the people that show their vascular complications, it's that line between the ICAP and the nipple, because you have sacrificed that blood supply, which makes sense. The other important question is, when I do, for example, chest wall perforator, I don't always dissect the vessel. I always know where the pedicle is. I have the blood supply in the pedicle. I know that my flap is alive, and I don't skletinize the vessel. Here in some of your beautiful videos, you're showing the vessel, sometimes you're showing the nerve. But do you need always to skletinize that or not?
No, it's just for the objective was to show where they are, and that with the camera you can have the proof that why is this happening. But as you know, we do the same. So when you tailor a flap, you don't go to see where in the chest wall the perforator is. You know it's alive, you can rotate it, and that's it.
And that's perfect. Those are the main points that I wanted to address. And I remember a couple of months ago when you came to Aberdeen, to Scotland, you showed us those ICAPs beautifully on the cadavers, and we cannot thank you enough for that.
Bueno, gracias Alberto, excelente la presentación. Vamos a continuar. Como dijimos, por honor al tiempo, nos va a presentar ahora el doctor Nicolás Fusco, que es miembro de la División de la Anatomía Patológica del Instituto Europeo de Oncología. Y el moderador va a ser el doctor Hugo Japace.
Hello, thank you, Dr. Scheidman, for the presentation. And first of all, I would like to thank the organizer for inviting me to Cáncer de Mama 2023. I'm honored to be here. And most of all, I'm honored to discuss with you about the biomarkers in triple negative breast cancer. This is the topic of my today's discussion. I think that you can see my screen now, and let's move to the very beginning of the story of breast cancer. These are my potential disclosures. So in this historical time, we are living an era in which the biomarkers in breast cancer are multiplicating. So that means that we are facing novel challenges in the diagnostic field, but these challenges are positive challenges, because these mean that our patients are going to have much more opportunities to improve their survival. So many types of biomarkers have been validated in the past few years, starting from novel biomarkers to the review of previously validated biomarkers in view of novel indications. So at present in breast cancer, we have tissue-based biomarkers and liquid biopsy-based biomarkers that can rely on different types of technologies. And I will discuss with you about the most clinically relevant ones. So, first of all, I would like to discuss with you about the immune biomarkers in triple-negative breast cancer that are actually particularly significant in the clinical practice. We have in triple-negative breast cancer an important anti-tumor immune response that can be actionable from the clinical point of view. And in this respect, several biomarkers have been validated in the clinical practice, most of all PD-L1, but also the tumor-infiltrating lymphocytes, as well as the mismatch repair microsatellite instability status. PD-L1 is a biomarker that is predictive of response to immunotherapy in triple-negative breast cancer, in metastatic triple-negative breast cancer, and in early breast cancer for the that can be treated with a neoadjuvant therapy. However, the biomarker is validated only for metastatic triple-negative breast cancer, given that in the neoadjuvant setting, the immunotherapy can be administered regardless of the expression of PD-L1. So the clinical setting is represented in this slide. You can see that estrogen receptor and progesterone receptor, the hormone receptors, should be negative, meaning that they should be completely negative, or negative in less than 1% of the, or positive in less than 1% of the tumor cells. On the other hand, HER2, that as well as estrogen receptor represent a spectrum of expression, can be, of course, negative, but also can be positive at immunohistochemistry, providing that there is no gene amplification. So the HER2 low category, meaning score 1+ or 2+ without amplification, is negative, in situ hybridization negative, are comprised in the triple-negative breast cancer definition up to date. So the situation is this one, more or less represented in this figure. We have two compounds, immunotherapeutic compounds, that are validated for metastatic triple-negative breast cancer, namely pembrolizumab and atezolizumab. The PD-L1 testing is used to select patients that should be treated with one or the other compound. What it changes is the type of scoring system and the type of assay. So for pembrolizumab, we have the combined positive score, the CPS, that is the validated scoring system, with validated assays, namely the DACO22C3 and the Ventana SP263. These are the validated assays for CPS. However, the companion diagnostic in the keynote trial that led to the approval of pembrolizumab used the DACO22C3 on an autostainer Link48 platform as a companion diagnostic test. So the CPS takes into account the membrane positivity of PD-L1 on both tumor cells and neoplastic cells and immune cells. And all of the sum of the positive cells should be divided by the number of viable tumor cells multiplied by 100. The cutoff value for patient eligibility to immunotherapy is 10. So CPS more or equal than 10 means that the patient can be treated with pembrolizumab. On the other hand, in the right-hand side of the slide, there's atezolizumab, in which we have only one validated assay, that is the SP142 from Ventana, that used another types of scoring system, is the immune cell score. The immune cell score takes into account the positivity only in the immune cells and divides this number by the tumor area. So it's not the number of neoplastic cells, but the tumor area, and multiplied by 100. In this case, the cutoff value is 1%. So CPS more than equal than 10 and I see more or equal that 1% are the cutoff value for the treatment with pembrolizumab and atezolizumab respectively in triple negative breast cancer. As you can see, this type of analysis is extremely complex to take into account many variabilities, including the biological heterogeneity of breast cancer, the spatial heterogeneity, the temporal heterogeneity, the heterogeneity in the tumor immune microenvironment, as well as the heterogeneity of the different assays and platform for the same biomarker, different antibody clones, different validated assays, different scoring system, and different platforms. So again, we have a double type of heterogeneity: biological heterogeneity and technological heterogeneity. And I would like to show you the results of a study that we conducted in Italy, including more than 120 pathology labs across the entire Italy, including the islands. And it is quite representative of the different healthcare environments, including small hospitals, wide, big hospitals, cancer centers, specialized cancer centers, or general hospitals. So the cohort is very representative of our healthcare system. And we asked our colleagues the type of immunohistochemical platform that they have and the type of assays that are available in their labs to carry out the PD-L1 testing. And as you can see in the right-hand part of the slide, different types of assays and different immunohistochemical platforms are present across the different types of hospitals and centers. That means that in a small country such as Italy, there's an incredibly high heterogeneity in the options for the testing of the same biomarkers. Therefore, we need to harmonize the testing, and in order not to preclude any possibility to the patient based on where the test is carried out. So we decided to verify whether the different assays and platforms are reproducible, and also we decided also to assess the reproducibility of the pathology testing for PD-L1, CPS, and IC scores. And we asked 5 trained pathologists to assess the 3 validated assays for PD-L1 on 60 metastatic triple-negative breast cancer samples, including samples with challenging cutoff values, such as those that are around CPS 10, those that are around IC1, in order to define whether the 5 trained pathologists can be reproducible. And we observed that, providing that the pathologists are specifically trained for PD-L1 testing, their reproducibility is high, and also not only the inter-observer reproducibility, but also the inter-platform reproducibility, meaning that for CPS scoring, the 2 validated assays providing harmonization can be used interchangeably, so that this type of analysis cannot be precluded to any patient, providing that the lab has at least one of these 2 types of assays. On the other hand, the only validated assay for IC score, the SP142, showed an extremely high inter-observer agreement. Actually, it was 100 agreement, and that's an extremely important result. When we compared the agreement among CPS and IC scores, we observed that there's no agreement, meaning that these 2 types of analysis select different cohorts of patients. So you cannot use, we are not allowed to use the SP142 or the IC score to select patients for pembrolizumab and vice versa. So each indication should have its own scoring system with validated assay. So, of course, in this era of digital pathology, we believe that the testing for this type of immune-related biomarkers will be absolutely improved, not only for the sensitivity and specificity, but most importantly for the reproducibility. That is an extremely important task. So PD-L1 is a typical tissue-based biomarker. But now we have several other options for additional and novel biomarkers that can be tested on circulating tumor DNA, so on liquid biopsies in breast cancer. And I'm talking about PI3K and ESR1. So let's start with PI3K. PI3K is a type of gene that shows somatic mutations in approximately 40% of hormone receptor positive HER2 negative metastatic breast cancer, and is associated with endocrine treatment resistance and with shorter survival rates. Usually, the regions that are they show alteration in PI3K are those in the exon 7, 9, and 20. However, as you can see in the lollipop plot in the top right-hand part of this slide, you can see that in addition to the hotspot regions, such as those that I'm highlighting now, the alterations in breast carcinomas can be virtually present in the entire gene. However, what is important for us is to identify the activating mutation in PI3K, because they can be actionable in the clinical practice. At present, we have alpelisib, that is a compound that is a PI3K inhibitor, but is in advanced stage of validation and prospective clinical trial inavolisib, that is another PI3K inhibitor. So how to test for PI3K? PI3K can be tested both on circulating tumor DNA and on tissue. But the circulating tumor DNA, of course, requires expertise and infrastructures that are capable of identifying these mutations on liquid biopsies. And this is the same, exactly the same story as for ESR1 mutations. So at present, the situation is represented in this slide. So in pathology lab, we for PI3K testing, we have some options that should be taken into account, and some choices that should be taken into account. First of all, we have to define what sample to use for PI3K testing, meaning primary tumor, metastasis, bioptic samples, surgical samples, cytological specimen, or liquid biopsies. And it's not that one specimen is better than another. The choice should be made up taking into account the patient, so at a single patient level. So it's an approach that brings the precision medicine approach into the pathology lab. And not only the biosource is important, but also what testing method, meaning digital droplet PCR, real-time PCR, next generation sequencing. These types of analysis requires a discussion also for the technology. Again, we don't favor one technology instead of the other one. What we favor is the turnaround times and the cost effectiveness. So providing that the assays used are at least have at least the reference range that those that have been used in the clinical trials are validated. So providing that this reference range is overlapping, the technology is valuable. And in particular, real-time PCR and NGS can be used interchangeably. So as you can see, the types of assays that are actually present for PI3K testing target different regions. So therefore, again, as what we performed in the immunohistochemistry for PD-L1, we wanted to validate whether the testing of the tissue or over the liquid biopsy provides additional information. And we have demonstrated that regardless of the technology, providing the reference range that is that has some minimum requirement criteria, the plasma-based sample can be used can identify the mutation in 45% of cases. So this is a very good result. And the approach, first liquid biopsy, and if it's negative for PI3K mutation, go to the tissue, seem to be particularly useful. Another important information related to these types of testing is the heterogeneity of the different sequencing platforms that can be available. And again, this is another study with the same study design as the previous one, only with the type of technologies that are present across our country, Italy. And as you can see, not all regions have the same technologies. Again, we need to optimize and harmonize the types of testing. Talking about liquid biopsy, at present we have new indication for patients with estrogen receptor 1 mutation. Estrogen receptor 1 mutation are acquired during the clinical history of the patient treated with endocrine treatment, and they are acquired because they are related to resistance to this treatment. And therefore, for these types of analysis, we cannot rely on tissue samples. The first biosource to use is the plasma sample, because if you're going to test the primary tumor, unlike, for example, for PI3K, you will not find the mutation. The mutation is present on circulating tumor DNA and is also related to the metastatic spread and the tumor shedding. Again, for ESR1, we have different assays, NGS-based assays, digital droplet PCR assays, and these two assays, one is NGS and another one is digital droplet PCR, are used in the two most important clinical trials for drugs targeting ESR1 mutations. And as you can see, the reference range is more or less overlapping, meaning that the digital droplet PCR targets, the companion diagnostic targets 4 regions, exon 7, exon 10, and the NGS assay, in this case, it's an externalized NGS assay, target from exon 6 to exon 10. So the results can be particularly, should be harmonized, but they can be overlapping. So the type of metastatic spread is also related to the molecular landscape of each of the technology that you employ, but also the molecular landscape from the biological point of view for each of the tumors. And again, the crosstalk between ESR1 and PI3K in endocrine treatment resistant, together with the crosstalk of ESR1, PI3K, and PTEN, is a key to understand the biology that underpin the metastatic spread and the resistance to therapy. So this is going to be my last slide, and shows the current approach to newly diagnosed metastatic breast cancer. And as you can see, many biomarkers should be tested based on the treatment line of therapy. And starting from the tumor biopsy, of course, we need to assess the traditional receptor status, estrogen receptor, progesterone receptor, and HER2. We in particular focus on HER2 low. I didn't talk today because of the time or the lack of time about HER2 low, but it's another important topic in breast cancer, both in the early and metastatic setting. But also, we need to perform genomic testing to inform the second-line treatment. So this is a proposal, of course. At present, we don't have guidelines for that, but it's a proposal that has a rationale. So at the point of the tumor biopsy, you can already get information for second-line treatment, including PI3K, BRCA, ESR1. In this case, you can use liquid biopsy if the tissue fails. On the other hand, if after progression to the first line of therapy, of course, you need to test ESR1 on liquid biopsy, or to test the PI3K based on the possibility to administer alpelisib or PI3K inhibitors to these patients. And of course, in the setting of predictive molecular pathology for PARP inhibitors, BRCA1 and 2 testing is extremely important. So this type of biomarker testing and predictive molecular pathology is evolving and is changing radically, and most importantly, is changing very, very fast. So pathology labs, together with the multidisciplinary team, together with oncologists, together with surgeons, need to be aware that our institutions, our politics should adapt very, very fast to the new opportunities that are present for our patients. So if a center is not able to carry out the minimal required analysis from the molecular point of view, both on tissue and liquid biopsy, we should work in networks or to externalize the sample. Only with this we can offer to all of our patients the maximum and the cutting edge opportunity that they deserve. And I thank you so much for your attention, and fully available to answer to any question you may have. Thank you.
Gracias, doctor Fusco. Doctor Japace, Hugo, te podés conectar y hacer las preguntas al doctor.
Hello, everybody. Nicole, thanks for inviting me. I have two questions. Number one, in a liquid biopsy, which are the most important pre-analytical key to obtain optimal result? And the other question, so I won't take your time because I need to hear you. By the way, excellent conference. It was an excellent up-to-date of this problem in your conference.
Thank you.
The second one is how reliable and reproducible is the HER2 ultra-low diagnosis? Please. Thank you.
Okay. Thank you, Dr. Japace, for the two most interesting questions. And actually, they are questions that should be treated with caution. So first of all, in liquid biopsy, the pre-analytical issues are crucial. When we talk about liquid biopsy at present, we are only talking about testing mutational status on circulating tumor DNA. And these types of analysis is carried out on plasma samples. So the pre-analytical workflow should be completely different than that workflow that we have for laboratory analysis on blood and on plasma and or serum. So we need to have a dedicated workflow with dedicated tubes and also controlled transport to the molecular pathology lab, temperature controlled transport to the molecular pathology lab, and most importantly, PRACT. So in order to avoid the risk that is an important issue of liquid biopsies, and in particular when the pre-analytical factors are not taken into account, is the increase in numbers on false negative results. So this is something that we don't know. Therefore, together with Dr. Cristian Rolfo and Umberto Malapelle in the International Society of Liquid Biopsies, we are at present writing the recommendation on pre-analytical and quality controls requirement for liquid biopsy samples. It's an extremely important topic because at present we don't have widely adopted guidelines for liquid biopsies. So together with the Quality Control and Accreditation Committee, I'm the chair of the Quality Control and Accreditation Committee in the International Society of Liquid Biopsy, we are developing international guidelines for the minimum criteria for pre-analytical control on liquid biopsies. Moving on the second question, the reproducibility over to ultra low. The reproducibility over to ultra low is extremely important. They will have some additional information when the next ASCO and the next ASCO will have the results from the Destiny Breast 06 that included for the treatment with antibody drug conjugates, TDXT, trastuzumab deruxtecan, also patient with HER2 ultra low, is becoming more and more important. For HER2 ultra low, we consider the patient that have an immunohistochemistry score of 0, but with expression of the HER2 protein in less than 10% of the tumor cells with faint or very perceptible positivity. So the reproducibility here should be the pathology community, the worldwide pathology community should work on the reproducibility, because up to now the distinction between ultra low and 0 was not clinically relevant. But now that is becoming clinically relevant, we need to train, we need to continuously train, and also we need to take advantage of the harmonization, as well as we did previously for the HER2 testing, for the traditional HER2 testing. I think that in this respect, additional molecular testing, such as on mRNA or gene expression profiling, would help in improving the reproducibility, and also digital pathology tools.
Excelente presentación, felicitaciones, doctor Fusco, excelente, doctor Japase, muchísimas gracias. Y muchas gracias por su participación. Por honor al tiempo, debemos dar paso, por favor, al próximo disertante. El próximo disertante va a ser el doctor Christopher Comstock. Él es radiólogo del Memorial Sloan Kettering Cáncer de Nueva York, y el moderador va a ser el doctor Darío Sheckman.
Okay, thank you. Thank you for inviting me, and I'm Christopher Comstock from Sloan Kettering, and in this talk I'm going to cover exciting new areas in supplemental screening for patients with intermediate risk for breast cancer. I'm not covering, we already have our standards for patients who are high risk according to the American Cancer Society guidelines. BRCA, 1 and 2 gene carriers or first degree relatives, or patients with a 20 to 25% or greater lifetime risk of breast cancer. Now, those patients are already getting, in addition to mammography, they're getting supplemental full breast MRI. So I'm not going to cover this topic, but in the future, with the new types of abbreviated breast MRI, we may see MRI converge into one form of MRI screening program. We know that mammography, annual screening mammography through the multiple randomized control trials reduces mortality from breast cancer by 20 to 40%. But we know that mammography is limited by breast density. Sensitivity is inversely related to breast density. And surprisingly, for those early randomized control trials where the technology and the technique of mammography back in the 70s and 80s was not very good, even with that poor technology and low sensitivity, it resulted in a significant reduction in mortality. So the question is, if we improve our methods, does that translate to an even better reduction in mortality? And, I would argue for that. And we know the biggest limitation we see are in women with dense breast tissue, where because of the masking effect, cancers can be obscured. Now, in the United States, because of the shortcomings of mammography, there's been some legislation that is a national, at the national level, which mandates that centers inform patients who, when they have their mammogram, who are in the top two density categories, ACR C and D, or heterogeneous and extremely dense, that they should be notified that their mammography may not be as effective and they may be at higher risk for breast cancer. And that's resulted in a proliferation in the United States of whole breast screening ultrasound because it's the most familiar with the referring physicians. It's most widely available. And so the current landscape of screening in the United States for intermediate risk patients with dense breast tissue is combined mammographic, either 2D or tomosynthesis, with whole breast screening ultrasound. And it's not a very efficient method with a low PPV, a high short-term follow-up. It's fairly time-consuming and it's fairly costly to only result in a slight improvement in breast cancer detection. Now, most of our studies were in higher risk patients with whole breast screening ultrasound, but the rate of detection in intermediate to average risk is probably around 1 or 2 cancers per 1,000. So it's not a very efficient screening methods. And so we've looked into ways where we can make a more efficient, more sensitive screening program. And that's where mostly I'm going to focus here on new advances in screening, which would be vascular-based screening methods, which include abbreviated breast MRI and contrast-enhanced digital mammography. And I think, one of our quickest fixes and improvement in reducing the number of women who die from breast cancer every year is the underdiagnosis that occurs at our current screening methods. And so even with digital breast tomosynthesis, 3D mammography, and added with whole breast screening ultrasound, we're still missing quite a few cancers. And I think if we have some simple, quick methods that can, and I'll show you the data in the next few slides, we can easily double our sensitivity at screening, which should result in fewer deaths from breast cancer. Now, if we look at digital mammography, this is from the DEMIS trial by Etta Pisano, we see that the sensitivity in dense breast tissue, the top 2 categories, heterogeneous and extremely dense, was less than 40%. And we know that mortality from breast cancer is directly related to the size of the invasive component at diagnosis. So the whole premise of screening is that can we find cancers at a smaller size and earlier stage, which would obviously translate to a reduction in mortality. And vascular-based screening, and the reason this is more effective is versus ultrasound and mammography, which are morphologic based. In other words, when you look at the images, you're relying on seeing the tumor, the shape, the margins in order to detect it. And that happens fairly, particularly in dense breasted patients, that happens particularly late. Now, with vascular imaging, it's not limited by breast density because we don't have to wait to see the tumor at a certain size. We actually can see the vascular changes that are related to angiogenic growth factors of invasive tumors and some DCIS, which create abnormal vascularity that can be detected when the tumors are at a much smaller, smaller size and earlier stage. And so here's just some classic examples of, 2 different mammographic patterns, heterogeneous and extremely dense, where those were both read as normal, and that we see clearly the vascular-based, in this case, MRI shows diffuse DCIS, and in this case, an invasive tumor. Here's another example, 2 examples of a patient with injected silicone, a heterogeneously dense mammogram with an easily visible 8mm invasive ductal seen on MRI. And in the right set of images, a heterogeneously dense pattern with an easily identifiable invasive cancer seen on the contrast mammography image. So the one thing I always question our residents and fellows, and when I ask them, I think there's a misperception on the sensitivity of mammography. I think in the past you ask people and they mention that it's 60 or 80%. That all depends on your reference standard. If you use a 1-year follow-up, that may lead to a 60 or 80% sensitivity. But if you use other gold standards, in this case, this is Wendy Berg's whole breast screening ultrasound trial, we see that MRI is the gold standard in this group of patients with both combined mammography and ultrasound. There were 26 total cancers. And you can see that mammography alone only detected 8 out of the 26, so barely, just over 30% sensitivity. Combined mammography plus ultrasound only found less than half of the cancers at 11.4 total. So we can see that vascular-based screening, this is based on full breast MRI, has a dramatic increase in sensitivity. Now, the problem has been that MRI has always been looked at as a very expensive, time-consuming test, and so we've reserved it only for our high-risk patients. But we know it's our most sensitive test. It's not limited by breast density or involve ionizing radiation. And so we really needed to change the mindset of breast MRI and try to make it much more accessible to more patients, particularly, obviously, patients with dense breast tissue and at average and intermediate risk who want screening more than just ultrasound. Now, Dr. Sung at Sloan Kettering also published that vascular-based imaging also has an advantage in that it detects the most biologically aggressive tumors compared to mammography in green, which is preferentially detects the lower grade invasives and DCIS, whereas MRI in blue is detecting the high grade lesions. So this is a concept of you have to think about not only for a modality, the cancer detection rate, but also the biological detection profile. You want a modality that's detecting the most aggressive cancers early. And so this is where the concept of abbreviated breast MRI came about. How can we make MRI more accessible along the lines of whole breast screening ultrasound? And that's done by reducing the scan time to about 10 minutes or less. And that'll allow you to scan potentially 3 patients in one time slot versus 1. So you could cut the cost in about a third and get that price similar to whole breast screening ultrasound, at least in the United States. And so that's where the direction when I took over the ECOG Akron co-chair, imaging co-chair of the breast committee is we really felt like we wanted to do a solid, scientifically designed evaluation of abbreviated breast MRI. Prior to this, most of the data, and in fact, all of the data came from patients who underwent a full abbreviated MRI, and then they did reader studies where they stripped out sequences. This was going to be patients who received only the abbreviated breast MRI. I invited my co-investigators, Christiana Kuhl and Gillian Newstead. I'll just quickly go to the results of the study, but it was a paired design. All patients got both tomosynthesis and abbreviated MRI, and we wanted to compare the invasive cancer detection rate as well as the overall cancer detection rate. We published these results in 2020 in JAMA, and the results are quite amazing, but as a phase 2 study, there's a lot of important information other than just cancer detection rate. We showed that the ABMR at these centers, a lot of them had never performed the abbreviated MR, did the scan in less than 10 minutes and averaged 8 minutes, and that 96% of women were able to tolerate the study, and there were very few false side effects, adverse effects. Now, I didn't mention, but what is an abbreviated breast MRI? Well, basically, in order to detect cancer with MRI, you need at least a pre-contrast and a post-contrast. That's the minimum required. And we added a T2 sequence to help improve specificity. But where we've reduced the time is that we've cut out the kinetics. So we, instead of doing multiple post sequences, we only do one post sequence. And we've shown, and studies have shown that that still results in a very high sensitivity, but really reduces the time. And just to get to the real important aspect is the trial of 1,500 patients had 23 women were diagnosed with cancer. Our current standard 3D mammography only detected 9. And the MRI detected, the ABMR detected 22 out of 23. So almost a twofold improvement in cancer detection. So it's a pretty amazing improvement in sensitivity. And the ABMR detected 10 additional invasives and detected all of the invasives detected on the tomo. The tomosynthesis did detect one DCIS not detected on the ABMR. And so that resulted in, for invasive cancers, 11.8 versus 4.8 for tomo. And for overall cancer detection, it was 15 versus 15.2 versus 6.2 per thousand. There were no interval cancers on that 1-year follow-up. Now, we're just presented at ASCO. Christian presented our results of the year 1 follow-up, because the first data I presented was on the baseline scan, where it's going to be the prevalence screen, and you're going to sweep out a lot of cancers. And so then on the subsequent prevalence round, we did see a drop in the overall incident cancer rate as expected, but we see that the MR still detected significant number increase in invasive cancers, and the tomosynthesis detected 3 additional DCIS. So you can see here 4.6 invasive cancers versus 1.5. And so really the study achieved its goal in proving that ABMR is a potential option for women at intermediate risk with dense breast tissue who want to have improved sensitivity. It can be done in less than 10 minutes. And it detects invasive cancers at a much higher rate. Now, lastly, I'm going to finish as another type of promising contrast or vascular-based screening is dual energy contrast enhanced mammography. And most standard, I received questions about which is better, which vascular-based screening. I think they're choices, and also it depends on access to MRIs, et cetera. But the accessibility of contrast enhanced mammography is quite extensive, because most modern mammographic units can be converted without a lot of very easily to do contrast mammography. And the premise of contrast mammography is patients get an injection of iodine similar to CT-based contrast, and the unit takes instantaneously, not really noticed by the patient, but the injection is given about 2 minutes before the mammographic views. And during the mammographic exposures, there's a high and a low energy, which one is above the K edge of iodine and one is below. And so to the patient, other than the injection and the 2-minute delay, they undergo a mammography, which is very familiar as their usual mammographic screen. Sloan Kettering is doing quite a few. We do sometimes 10 to 14 a day. Not quite as many as we do breast MRI, but getting pretty close. And these are in patients who are intermediate, average to intermediate risk, who come from our high-risk screening clinic, who don't qualify for MR. And so this is an option for them. And we've seen that in our patients, we had, in our first 1,000 patients, we had 15 cancers. 7 additional out of those 15 were found only on the recombined contrast images. And we see a big jump in sensitivity with contrast mammography versus the low energy. Now, the beauty of contrast mammography is that with the supplemental ABMR, if you want the highest sensitivity, because as I mentioned on the 1-year follow-up, the tomosynthesis added 3 additional high-grade DCISs. If you want the highest combined program, you do it as a supplement. So with abbreviated breast MRI, patients would have 2 different tests. The beauty of contrast mammography is you have both the low energy, which is your 2D mammogram to detect calcifications, and then your contrast image all in one setting. But if we look at the numbers, it looks like the contrast mammography is not quite as sensitive, but probably almost a little less than a doubling of cancer sensitivity. So it's an option. It may not be as sensitive, but again, it has much wider availability, and it's combining both your mammographic and vascular in one test. Here's an example of a very challenging mammographic pattern. You'd be hard pressed to detect the cancer based on that. And now if we look at the contrast image, we clearly see the small invasive cancer. So you can easily see the power in patients with dense breast tissue. Here's another cancer, heterogeneously dense pattern, and a small invasive cancer that is seen on the contrast images. And so in order to evaluate, similar to the ABMR trial, I'm chairing another multi-center trial similar to the ABMR trial. It's run by the ACR, American College of Radiology, funded by GE Medical and the Breast Cancer Research Foundation. And it's a very similar trial to do a paired design to look at the phase 2 data. Because right now, contrast-enhanced mammography for screening is not FDA approved in the United States. Many centers like ourselves do it as an off-label use because we see that it's at least or not better than the standard of care, which is mammography plus ultrasound. So this is about a 2,000 patient study. We've just opened it at 4 centers. We hope to have about 14 centers by the beginning of next year. And we hope to publish the results, after the accrual of 2 years and the 1-year follow-up. So this is another important trial looking at the performance of emerging vascular-based screening. And these are, again, patients at intermediate to average risk. So I think this is an exciting time. I think we're really going to usher in a new paradigm in breast cancer screening, particularly, obviously, in women with dense breast tissue at intermediate and average risk. I think for abbreviated MR, we'll see new methods, and we're already incorporating this into our protocols, ultrafast, which I don't have time to cover, and diffusion-weighted imaging. And obviously, we need I think AI tools. There's promising work by Connie Lehman, MIT, and at Harvard, where we see that there's a very powerful signal in the radiomics of mammographic patterns, which could really help to tailor who should have these studies, not only who should have them, but also how frequently, to really optimize the detection and minimize false positives and cost by tailoring screening to the appropriate level for each patient. So thank you very much for inviting me, and sorry, hopefully I didn't run too far over.
Muchísimas gracias, doctor Comstock. No fue rápido, fue muy clara su presentación. Quería hacerle un par de preguntas nada más. Una es siempre hablando de screen de riesgo intermedio, ¿no? Alrededor del 15 al 20%. ¿Cuál sería, ustedes les ha incrementado la tasa de falsos positivos o la tasa de cantidad de punciones, biopsias por resonancia que tienen que hacer?
Right. So, as with MRI and contrast mammography, for both those tests, they're going to detect vascular enhancing lesions that you haven't seen in the past. So both tests on the baseline study are going to have additional callbacks. So you're going to expect on the baseline anywhere from, for contrast mammography, about a 15% to 20% either workup or callback or short-term follow-up. That improves when you now have comparison studies, and you can now see that there's stability in those findings. But yes, it's something that for both MRI and for contrast mammography, we need to work on, with particularly maybe assistance with AI. We now have the contrast biopsy capability, contrast mammography. So in the past, we used to have to do a fair number of MRIs to see if it, and that was our only source of doing the biopsy. But now with the biopsy capability on contrast mammography, it's very similar to a stereotactic biopsy. So it's a concern, and obviously something that we need to work on in terms of false positives, but it's similar for both tests.
Sí, perfecto. Y a medida que vamos teniendo más ruedas de seguimiento, los falsos positivos van disminuyendo según los estudios. Y en caso, usted habló de los dos métodos realmente que se están utilizando hoy en día, tanto la resonancia magnética como la mamografía por contraste. ¿Usted cree que, por ejemplo, para el screening de riesgo intermedio sería más adecuado la mamografía con contraste y para el alto riesgo sería más adecuado la resonancia o los usaría de acuerdo a la disposición?
You know, it's a challenging, you know, I guess we're going to see where the cards fall, because it's a very common question is, there may be patients who I want the most sensitive test, and it may come at an additional charge because currently, insurance here in the United States isn't covering that. So, for instance, centers offer a cash payment for abbreviated MR on the range of $300 to $500. Whereas with contrast mammography, most centers like ourselves, we can bill for a digital mammogram, and that's covered by insurance. And then we only, it's the only issue is the cost of the contrast, which is not very expensive. So I think from a wide population, access, availability, and cost, I think contrast mammography really is the route for that. And then I think, maybe we use for patients who are in between kind of intermediate to high, maybe we use the abbreviated MRI. So I don't have the answer, but clearly the contrast mammography is much more accessible, and again, it has a mammographic screen combined with a vascular screen. So I think it'll be options for women to decide, but also it depends on what you have available and access to.
Muchísimas gracias, doctor. Me encantaría seguir conversando este tema porque creo que es muy interesante, pero bueno, tenemos que seguir con todo el cuadro de hoy. Muchísimas gracias por su participación. Le cuento que ya tenemos más de 1.200 personas que han escuchado su clase, así que muchísimas gracias. Y bueno, vamos a seguir con el doctor Virgilio Sacchini, que es Attending Surgeon of the Department of Breast Surgical Oncology del Memorial Cancer Center de Nueva York, y la moderadora va a ser la doctora Fernanda Barbosa. Dr. Sacchini, if you want, you can share your lecture and
Yes, thank you so much.
Okay.
Thank you for this kind invitation, and it is a special pleasure for me to be here at this annual appointment. And I would like to share with you some new algorithms that we are applying here in the normal treatment of breast cancer at Memorial Sloan Kettering, as well as some clinical trials that we have now in progress. And I don't know if you can see my screen now. So the magic word in this last 10, 15 years, even more, was the de-escalation. De-escalation in breast cancer treatment, de-escalation for surgery, de-escalation for radiation therapy, de-escalation for chemotherapy, and starting in 2004, stopping radiation for small cancers in old women, be a little more concerned on prophylactic contralateral mastectomy. 2011, the Z11, avoiding axillary dissection in lymph node with positive metastasis. Choice wives more than 70 years old with small cancers, try to avoid the axillary dissection, stop chemotherapy in positive lymph nodes when the oncotype is low, a Taylor trial. And I would say finally this year the Sound trial, again Milan as a leader in these trials, the last trial designed by Professor Veronesi, just published in which we can avoid in some cancers to do surgery in the axilla to stage the axilla, and this is the randomized study in N0 small cancers less than 2 centimeters, candidate to conservative surgery with a negative ultrasound. The patient was randomized to no axilla when the ultrasound was negative, or the usual sentinel lymph node policy. Axillary dissection when the sentinel node was positive was only done in micromet, and this the result, 6 years follow-up, no difference in distant disease-free survival, no different in disease-free survival, and no different in overall survival. This is a great result again, and I mention in this trial because this will be the next algorithm that we would apply in the treatment of breast cancer here at Memorial Sloan Kettering. And this de-escalation of the treatment of breast cancer was made possible by better integration of the treatments that we have now for breast cancer surgery, of course, radiation, hormonal therapy, chemotherapy, target therapies, immunotherapies. And we can quantify the prediction of the success of each treatment. We are able more and more to say, well, the radiation may work better in this type of cancers, and we may invest more in radiation than in surgery or chemotherapy, hormonal therapy. This is quite obvious, of course, in HER2 positive cancer with the target treatment, in which the response to the treatment neoadjuvant is great. So we invest more in the neoadjuvant as well as the triple negative breast cancers. Of course, a little questionable is still the prediction in ER/PR HER2 negative cancers, the luminal cancer. Even if with the genomic, we use a lot Oncotype, MammaPrint, we can really predict better the response to treatment, to the chemotherapy or to the hormonal therapy. This is a very interesting study in which the Oncotype score was very correlate to the pathology response after neoadjuvant chemotherapy. There was an attempt, of course, the genomic is quite expensive, cannot be done everywhere, and there was an attempt to try to use the Ki-67 proliferation index, and we can say that we can predict in a good way. This is an experience by Mayo Clinic, the effect of the chemotherapy in luminal patients. And this is the algorithm that we are using now at Memorial Sloan Kettering in, of course, N0 patient, luminal patient. We use genomic to decide the adjuvant chemo versus hormonal therapy. And in clinical N+ patient, we use the genomic before deciding the treatment, and when the score is low, we proceed with the surgery right away. And when the score is high, more than 25%, we decide for neoadjuvant chemotherapy in this patient. And of course, someone may argue why you don't do hormonal neoadjuvant treatment, but it's of course something that may be in progress. Interesting to note that the genomic oncotype in this situation can also predict the result of the radiation therapy in these luminal patients, low oncotype score has a very low risk of local recurrences without radiation therapy. And that's the reason why we establish here at Memorial, we are running this trial, the so-called IDEA trial, in which in patients more than 50 to 65 with small cancer, less than 2 centimeters, free margins more than 2 millimeters, non-negative, of course, and oncotype less than 18, we don't do radiation therapy. Is of course a surveillance trial. In the last 10, 15 years, we were very, very committed in reducing as much as possible the risk of lymphedema. And lymphedema is now, in this moment, one of the most important sequelae in surgery of breast cancer, with the better reconstruction, conservation, conservative mastectomies. We were able to improve a lot the quality of life, but after the axillary dissection, the risk of lymphedema is quite high. This is our study published in JAMA last year, showing 23% of the risk of lymphedema when you do the axillary dissection. And one of the risk factors is the ethnicity. It means the Afro-American, the Hispanic, they have a high risk of the lymphedema, probably because the fibrotic reaction is much more in these populations. Interesting to know that also neoadjuvant chemotherapy is a risk factor, and we don't know, probably the chemotherapy may give a sort of fibrotic reaction after axillary dissection. That's the reason why we are really committed to decrease as much as possible the need of an axillary dissection, the need of course, removing the lymph nodes if the lymph node is positive. And this is our study in progress, in which in clinical positive lymph node, we try to avoid the axillary dissection. Of course, when the patient is not candidate to neoadjuvant chemotherapy, especially in luminal cancer. And the background is that we know the Z11 trial, when the patient is eligible for conservation therapy, if the patient has less than 3 lymph node positive at the final lymph node biopsy pathology, we can skip the axillary dissection in spite of the 27-30% risk that other positive lymph nodes may be present, but again, the integrate treatment, chemotherapy, radiation therapy, hormonal therapy, can clean up the residual disease in the axilla. And again, the background is that often in this N1 palpable lymph node patients, at the end of the story, when you do the axillary dissection, you may find in about 40% of the patient less than 3 positive lymph nodes. So why not to apply the same criteria in these patients? So in C T1, T2 patient, palpable lymph node with the positive cytology and an ultrasound showing less than 3 positive lymph nodes, abnormal lymph nodes, I would say. We do the sentinel lymph node biopsy, and if the node was clipped, we remove the clipped node, and then we weigh the final pathology. If at the final pathology we have less than 3 positive lymph nodes, we apply the same Z11 criteria. We don't do the axillary dissection with more than 3 lymph nodes. Of course, we proceed with the second surgery and axillary dissection. Sometimes we do frozen section, and if we have more than 2-3 lymph nodes positive, we proceed right away with axillary dissection. This is, of course, of observational study in progress. If we need to do the axillary dissection in all patients, there is our clinical trial, randomized clinical trial, comparing patient with lymphovascular anastomosis during the axillary dissection versus nothing, the conventional axillary dissection, and we inject a tracer in the hand, in the arm, seeing the lymphatic coming from the arm, and doing a sort of anastomosis, a microanastomosis with the collateral axillary vein. Usually when we do this axillary dissection, we try to save the external mammary, also called brachial lateral thoracoepigastric vein, and we do this. We randomize the patient to have or not the lymphovascular anastomosis. The trial finished. We concluded the trial, and the result of the trial, I can tell you, is excellent. And for this reason, we're going to publish, of course, but looking at the preliminary data, we are offering now lymphovascular anastomosis during our axillary dissection in all patients. Of course, we are committed to have more and more good cosmetic results when we need to do the niposperinmastectomy, the mastectomy in general. Niposperinmastectomy was a very good improvement. Sensation, of course, is a big issue, and I was fascinated by the presentation of my friend Rancati with the nerve sparing. But I can tell you that sometimes the nerve sparing is not so possible because the nerve may enter the breast tissue, and especially if you have a cancer, is a little of concern. So what we do is a sort of neurotization, anastomosis using cadaveric nerve or intercostal nerves to try to preserve or to give back the patient this sensation in niposparin mastectomy, another study in progress. And speaking again about the improving the quality of life of our patients, we are running a special trial on locally advanced breast cancer. So what's happening that locally advanced breast cancer, inflammatory breast cancer, T3 breast cancer will require neoadjuvant chemotherapy, and then will require the mastectomy, modified radical mastectomy, and then radiation therapy, creating some issues with the reconstruction. We know that after the radiation therapy, autologous reconstruction or implant reconstruction may have bad cosmetic results. So we are trying to invert the sequence to do chemotherapy, to prove a good response, to do radiation therapy, and then to do the mastectomy with the reconstruction with the DF flap right way. This is the design of the study, clinical T4 and 0 and 2. And now we included T3 patients, partial or complete response. We do a biopsy. The response has to be more than 50%. And then and then we do radiation therapy, and 2 to 6 weeks after, we do modified radical mastectomy and autologous reconstruction. Of course, endpoints, wound complications, lymphedema, the pathologic complete response after the chemotherapy, possible, of course, complications. The integrate treatments where can really also improve the outcome of the patients. This is the first observation that we had when I was in Milan, 2002. I was with Professor Veronesi, responsible of the Milan trial 1, lumpectomy versus modified radical mastectomy, and we noted an increase of survival in a patient more than 1 centimeter with cancer, more than 1 centimeter, with respect to the mastectomy patients. Of course, we thought at the time that it was just a statistical problem, not significant. But now we know. This is the meta-analysis, more than 1,500 patients treated with conservation, radiation, and mastectomy without radiation, showing a little improvement of the survival. And the speculation is that the radiation can increase the immune response against the cancer. And this is another trial that we have in progress now, at Memorial, in some high-risk patient radiation on the cancer before the surgery. And so we do some radiation, and the radiation may fragment, may release antigens, creating a better immune response against the cancer. And this is our design of the study, triple negative, high risk HER2, ER2 negative, and we give patients radiation or not, is randomized, different dose of radiation. Then we treat the patient with neoadjuvant chemotherapy plus Prembo. We do surgery, and of course, the endpoint is the complete response that we may have, and the lymphocyte into the possible residual cancer. Speaking about neoadjuvant treatments, we were incredibly we were last year incredibly well impressed about the TDXD treatment, improving the survival in advanced breast cancer. And at Memorial, we are doing now, we are part of the Destiny Breast 11, in which neoadjuvant treatment in HER2 locally advanced positive breast cancer are treated with this medication. So we are translating we would like to verify if the benefit that we have in neoadjuvant can be in adjuvant, can be in neoadjuvant, and this is the design of this study, treating the patient with trastuzumab deruxtecan versus alone versus in combination or versus the conventional treatment, and of course with the PCR as first endpoints. Of course, we have to speak about the circulating tumor cells. This is another study that we are in progress here at Memorial Sloan Kettering, in which we would like to intercept the minimal residual disease as soon as possible, having different categories of breast cancers, in which, after neoadjuvant treatment, we can intercept the not responder, we can intercept the initial responder with early relapse, the cure patients, of course, and the late relapse patients. And this study, of course, is in progress here at Memorial on the circulating tumor cells. And we would like to shift the paradigm on the low-risk and high-risk patients based on the biology of the cancer, based on the stage of the cancer, versus the high-risk and low-risk patient based on the circulating tumor DNA, stratifying the patient at the beginning in patient with no residual minimal disease, or residual minimal disease, or at the beginning already circulating tumor DNA. And last, we are very, very committed in sequencing all our cancer, not only breast cancer, and we try in sequencing this breast cancer to find some therapeutical, not conventional action that we can do. And for instance, we are able in about 9% of our patients, when we sequence the DNA, to find some alteration, DNA alteration, that may be translating treatments already show benefit, or with the different level of evidence. This is the study that we have in progress now. We do in different cancer, we treat the cancer surgically, and then we analyze the genomic. In case we find a microsatellite stability, MSI, we randomly treat the patients after the conventional treatment with some immuno treatment. So I would like to conclude my lecture stressing that we are continuing the de-escalation of the treatments for better integration and sequence of the treatment that we are now, and we would have more and more. Of course, we would like to continue to improve the quality of life, and the next step may be to detect as soon as possible resistance to treatment through a minimal residual disease, and to find more and more target treatment in sequencing cancers more and more. Thank you so much for your attention.
Thank you, Dr. Sacchini. Congratulations on your lecture. It's great, as always. So we talk about a lot, and you talked a lot about de-escalating breast cancer surgery. And I have two similar questions regarding axillary surgery and de-escalating axillary surgery to lower morbidity. for breast cancer surgery. So 2 different scenarios. So one, you talked about luminal initial breast cancer. So you have an interesting fluxogram, nomogram for luminal patients with a positive lymph node. So if in this specific scenario for 1 or 2 positive lymph nodes, do you think we can proceed to do only sentinel lymph node biopsy, or do you think we still need to do axillary surgery? And the other scenario for patients with locally advanced disease, so N2 disease diagnosis, that undergo neoadjuvant chemotherapy and has an excellent response, both clinical and radiologic complete response. So do you think we can do sentinel lymph node biopsy in these cases, or if we should do axillary dissection also? So 2 different scenarios.
No, thank you, Fernanda. As usual, your questions are very, very appropriate and specific, and you're perfectly right. We would like to see if we have, in case we have less than 3 lymph nodes positive, palpable, and the patient doesn't require the chemotherapy and may not require the chemotherapy for the transponder trial, to avoid axillary dissection. So the answer is that we believe, and of course the study is an observational study. We have now 80 patients in the trial. And let's see. In N2 patients, the literature is showing 30% of false negative. They didn't do the clipping of the node, so this may be a little better. We have a trial. I didn't mention the trial because the trial is almost finished. In inflammatory or N2 breast cancer, in which we have we do the sentinel lymph node biopsy plus the backup axillary dissection. The false positive is not bad, but definitely higher. We don't clip the node, unfortunately. We are starting now. The false negative rate is 20%.
Okay. Perfect. Thank you.
My pleasure.
Okay, thank you very much, Dr. Sacchini. Okay, we need to continue. We need to continue with the last presentation. So thank you for both of us.
Thank you.
Muchísimas gracias a todos por seguir conectados. Somos 1.200 personas en vivo y vamos a presentar la conferencia del doctor Mark Robson, que él es jefe de la División de Medicina de Mama del Memorial Catering Center. Va a hacer la moderación el doctor Ernesto Gildesa. Lamentablemente el doctor no puede estar presente y nos envió la conferencia grabada. Dejo de compartir para poder brindar esta conferencia.
I apologize that I am doing this by recording. I had a family issue that meant that I was going to be on a plane at this time. So again, I'm grateful to the organizers for accommodating me. These are my disclosures, none of which are really relevant to what we're going to talk about today. So the topic for this morning is polygenic risk in breast cancer risk assessment. And this is something that's coming online and is unfortunately a lot more complicated than the issue of single gene predisposition like BRCA1 or BRCA2. There it's pretty straightforward, one mutation. We kind of have a pretty good sense of what to do. This is a lot more plastic, a lot more variable. And it's worthwhile going through it a little bit because it is starting to work its way into commercial diagnostic laboratories, testing, and eventually may hit the clinic. It's a little challenging right now for various reasons, but I do think it's important to understand the landscape. So I want to start with the idea that risk of breast cancer in the general population is normally distributed. So in other words, everybody doesn't have the average risk. The average risk comes about because some people are at high risk, some people are at low risk, and the great majority of people are somewhere in the middle. So the extremes of this are pretty significant. At one end of the extreme, the lowest risk women in the general population have about half the risk of the average, and at the highest, it's 2.5 times. So that is meaningful changes, and certainly could drive things like mammography utilization or other public health interventions. And under certain circumstances, you might be able to actually change individual screening based upon where you can put her in this normal curve. So why is there so much variation in risk in the general population? Well, we know that there are what we call intrinsic factors, which are host factors like reproductive, when did you have kids, when did you have your first period, did you breastfeed? There are environmental exposures, alcohol, potentially hormone replacement therapy, for instance. And then, of course, there are inherited factors. So there's a hereditable source of variation in that normal curve that I showed you. We've done a huge amount of work over the years defining rare variants that are associated with breast cancer risk. So these are the things like down here in the high side, BRCA1 or BRCA2, for instance. The rare variants that are moderate risk are things like CHEK2 or ATM. And this is what you look for when you're doing your standard genetic testing. But of course, these are not present in the great majority of people who have breast cancer. But the other thing that contributes to breast cancer risk is a large number of common variants, each of which has by itself a very small effect on risk. But when summed together, it can actually be meaningful. And there are literally hundreds of common variants that affect breast cancer risk. There may even be thousands. And they're scattered throughout the genome, and they don't necessarily cause dysfunction of a particular gene. As a matter of fact, many of them are in non-coding regions. And although we don't completely understand how they affect risk, the thought is that it probably has something to do, probably has something to do with gene expression levels, and potentially gene expression levels of genes that are well removed from the locus in terms of genomic location. There were a number of genome-wide association studies that were done in the early 2000s that defined the single nucleotide polymorphisms that are associated with both hormone receptor positive and hormone receptor negative disease. And the single nucleotide polymorphism is one of those locations where the two different alleles, so an A and a C, for instance, and one of them is present at greater than 50% of the population, the other is present at less. And sometimes the allelic frequency, which is what you see down here at the bottom, is present only in 10% of the population, or sometimes even less than 10% of the population. And this is the odds ratio or risk that's associated with each of these identified SNPs. The chromosomal locations are noted here. And what you can see is the vast majority of them have associated risk less than 1.2. So just for comparison, the risk of having a first-degree relative affected with breast cancer is about 2.2. So individually, each of these is pretty limited. There are a number associated with hormone receptor positive disease. There are a number associated with hormone receptor negative disease, perhaps fewer. And this is how you sum them. This is a complicated expression, but the overall polygenic risk score is fundamentally the odds ratio associated with the allele times the number of alleles that the patient has, 1 or 2. And then these can just be summed, and you come up with a total polygenic risk. There are some complexities in converting this into an actual relative risk, but for the purposes of this conversation, this is how you get to it. So in other words, each one of those individual loci that I showed you on the graphs before, you essentially sum up the risks associated with them. And what you find is that when you do that, the polygenic risk score in individuals who have breast cancer is on average higher than the polygenic risk score in those who do not. So this is a study of over 33,000 cases and controls. And the dotted blue line is the polygenic risk in the women who do not have breast cancer, and the red line is the polygenic risk in those who do. So you can see that although it is statistically significantly different, there is a tremendous amount of overlap, which hampers the use of this in individual risk prediction. But nonetheless, it's very clearly associated with the risk of breast cancer. These are different ways of showing this, but fundamentally what it is it's the percentile of the polygenic risk. And then on this end, it's the odds ratio associated with that percentile. This is it in a tabular form. And so if you take the middle point as an odds ratio of 1, Up in the very top percentile, women have a risk of 3.4 times that of general population or of the median. And in the bottom, it's about 0.3%. So these are significant changes overall. Polygenic risk is associated with contralateral breast cancer. Again, each unit of standard deviation of the polygenic risk is associated with 1.25-fold increase in hazard ratio. So these are not tremendously large, and interestingly, more of an impact on hormone receptor positive disease than there is on hormone receptor negative disease. Not yet at the point where we can use them for risk prediction, but at least proof of principle that there are things going on other than the rare variants that increase or modulate risk. Interestingly, the strength of the association decreases with age. This is difficult to see that there are indeed differences, but these are based on large numbers. And particularly for hormone receptor positive disease, the polygenic risk is more influential on early onset breast cancer than it is on later onset breast cancer, which perhaps makes sense because it may be that later onset is just due to the accumulation of mutations with age, and earlier onset may actually have something to do with predisposition. The family history is not all explained by polygenic risk, and polygenic risk is not all explained by family history. So they are independent things, but roughly 12 to 14% of family history is explained by polygenic risk. But if you think about it, polygenic risk cannot segregate in a Mendelian fashion because it's multiple loci, each of which is segregating independently. So the polygenic risk of an individual is not shared with his or her siblings. It's mixed together with the polygenic risk components from the other parent. And since there's 350 or 400 or 500 of those, each generation and indeed each individual is their own unique mix. Now, polygenic risk does modify the risk that's associated with rare variants. So this is just an illustration that in BRCA1 carriers and in BRCA2 carriers, polygenic risk modifies hormone receptor positive disease by a factor of either 1.11 or 1.22 per standard deviation, and hormone receptor negative disease by a similar amount. And not surprisingly, the hormone receptor negative PRS is more important in BRCA1, and the hormone receptor positive is more important in BRCA2. And what this means is that for an individual patient, if you take the median take the average as the reference point, the women who are in the lowest percentile have about a 25% reduction in risk, and women who are in the highest percentile have a 50 to 80% increase in risk compared to the middle group. Now, whether or not this is clinically significant is a whole nother issue, and we're doing a study right now to see whether or not providing carriers with PRS-adjusted risk scores has any influence on their decisional conflict with regard to surgery. And we probably can't move the needle enough in high-risk disease to have a clinical impact. Now, how do you assess the performance of a test, of any test, including the polygenic risk? Well, one way is by measuring something called discriminatory accuracy. And if you imagine a situation where you have green and blue people all mixing together in a crowd, there's something called the C statistic, which is the chance that if you randomly select a green and a blue, that the randomly selected green will have a higher PRS than the randomly selected blue. So if green is cases, blues are controls, what's the chance that a woman with breast cancer will have a higher PRS than a woman without? This is the same thing as the AUC of a ROC curve, for those of you who are used to using those for test performance. So the discriminatory accuracy of a polygenic risk score in BRCA1 is about 0.58, BRCA2 is about 0.56. This is not great. A discriminatory accuracy of 0.5 is essentially random. So this just illustrates that there's not a lot of difference between the PRS of those with or without cancer in the high penetrance groups. Now, the problem with using discriminatory accuracy as a statistic or as a measure of benefit is that something can be perfectly discriminatory. In other words, have a discriminatory accuracy of 1, but be completely wrong. So let me just illustrate this. You have a bunch of controls, and this is the PRS in those controls, and you have a bunch of cases, and this is the PRS in those cases. This is an example. This is not anything close to reality. So in this case, the PRS is going to be perfectly discriminatory because the case's PRS is always going to be greater than the control's PRS. But what this is telling you is that the average risk for the control is here. The average risk for the case is here. But what happens if the situation is this? It's still perfectly discriminatory, but the average risk is in a different place. So this isn't really giving you much help in terms of what's called calibration, which is the correlation between the test result and the actual outcome of the patient in terms of do they develop or not develop breast cancer going forward. Now, the way you look at this is looking at absolute risk, of course. And interestingly, if you apply polygenic risk scores to determine the absolute risk in carriers, you can see that it has an effect on women with female breast cancer, obviously female breast cancer, but the upper and lower bounds are people at the upper 95 and lower 5 percentile. And you can see there is a difference in risk here. It's a little bit greater for BRCA1 than it is for BRCA2. And the situation also applies in male breast cancer. So the gray line is the average risk. The blue line is men who have the 95th percentile polygenic risk. And the blue line on the bottom is those who have the 5th percentile polygenic risk. Now, you would think that this is great, except remember, there aren't very many people in the 5th and the 95th percentile. So the great majority of people are going to fall close to the gray line, and that's probably not going to help modify their clinical decision-making or whether or not they should do screening. Now, one place where polygenic risk might become useful is that it also modifies the risk associated with moderate penetrance variants. So this is now looking at a different experiment, looking at the influence of polygenic risk score. You can see again, percentile of the polygenic risk along the x-axis and 5-year absolute risk along the y-axis. And so BRCA1 and BRCA2, there's a fairly modest change. But it's a more meaningful difference for people who have alterations in, for instance, PALB2, ATM, or CHEK2. There's a more significant increase in risk of breast cancer as the polygenic risk score elevates. Now, the other way of thinking about this is that there's also a lower side of the polygenic risk score. And so when you look at polygenic risk in women who have pathogenic variants in so-called moderate penetrance genes like CHEK2 or ATM or BARD1, it turns out that a proportion of those women actually have a risk that is below the 20% threshold that's used for high-risk screening. So in the average risk population, the non-carrier population, women who don't have a family history, if you use polygenic risk adjustment, 95% of them are less than 20%. And even if you have a family history, nearly 80% are under the 20% threshold. On the other hand, if you have BRCA1, BRCA2, or PALB2, those have such a strong underlying predisposition by themselves, the rare variant, the polygenic risk modification doesn't bring many of them down into the average risk group. Whereas CHEK2, ATM, BARD1, for instance, anywhere between 30 and 65 to 70% of women in that group who have no family history don't have an elevated risk as currently defined. And even those who do have a family history, many of them do not. So 20% of ATM carriers with no family history, with a family history, don't have a risk of 20%. So this is why, aggressive surgical intervention in people who have moderate penetrance risk genes is not really appropriate most of the time, because there's a very good chance, well, there's a reasonable chance they're not even at increased risk. Now, are the ways that we can do this in conjunction with established absolute risk models to try to see whether or not we can improve other risk prediction? And the answer is yes. You can do modifications of both IBIS or Boadicea, which is now the CAN-RISK model. And when you include polygenic risk, you do get reasonable what's called calibration. So this is the predicted risk, this is the observed risk, and what you want is a ratio of 1. And most of these, as you can see, are pretty close to that 1 line. So in other words, you're able to assign risk accurately. Now, when you're assessing whether or not the new marker improves an absolute risk model, you have to see that if without the marker, this is called reclassification. In other words, they're below your 20% when you're not applying the marker. They're above the threshold when you do. And then that changes. In other words, they switch categories with the new with the new marker. And so that's called the net reclassification index. And you can also use it to calculate something called the net benefit index, which is weighted depending upon the outcome. But you do have to remember that just because somebody's reclassified with a marker doesn't necessarily mean they're reclassified correctly. And so you have to combine this type of assessment with some measurement of calibration of whether or not absolute risk prediction is accurate in order to determine whether or not the model is really improved by incorporating this extra marker. And so there have been a number of studies combining PRS with Cusick, BC-RAT, Bodicea, and also, of course, a lot of the companies, Myriad in particular, have their own models, and trying to generate what you would call an integrated absolute risk prediction for the individuals, particularly those who don't have strongly predisposing rare variants. Now, the problem is that doing this kind of combination assumes that the PRS and the model risk factors are independent, but you have to be careful because the models do include family history, and the polygenic risk accounts for some of the family history. So you have to make an adjustment to avoid double counting, if you will. And vice versa, the genetic component includes some polygenic risk, and so you have to adjust the genetic component for the polygenic risk as well. So if you don't make these adjustments, you can easily come up with an overestimation of individual risk. And again, the commercial enterprises who are doing this are aware of this and have made the appropriate adjustments to their models. I'll also leave you with the idea that it's not just polygenic risk, of course. When you start incorporating all the other things that could influence moderate penetrance risk, you wind up with a very complex picture and certainly a very wide spread of potential risks. So here, the line on the left, the vertical line on the left is population risk. And the red line is the median or the average estimated risk for a woman who has a CHEK2 alteration, and on the left, no family history, on the right, with a family history. So the average CHEK2 carrier has a predicted risk of around 20% if she doesn't have a family history and about 32% if she does. So if all you were doing was counseling that woman, that's what you would tell her. You would say you have a 20-something%, you have a 30-something% risk of breast cancer. But the truth is, for that individual woman, the number is probably not right there on the red line. And if you start incorporating things like questionnaire-based risk factors, these are usually the reproductive risk factors or mammographic density or the polygenic risk, or bringing them all together, you wind up with a much wider spread of risk. So the blue curves down at the bottom are the potential risks for these women when you start including all these different factors. So just to bring this home, the 20-year-old CHEK2 carrier, if you incorporated all the available information, there is an over 50% chance that she is below the 20% risk threshold. And as a matter of fact, there's a certain probability that she's even below the average population risk threshold. And even if you have a woman who has a CHEK2 alteration and a family history here, nearly 50% of them are going to be underneath the 20% risk threshold if you incorporated all the factors. So no, we're not quite able to do that yet, but I do think it is a cautionary tale for when you're counseling women who have moderate penetrance genes that the average risk may not necessarily be representative. And of course, the other point I'll make about this is that if you incorporate all these factors, some of these women have very high risks. So there's a certain proportion of women who have CHEK2, a family history, and then when you look at all the other factors, have lifetime breast cancer risks over 50%, certainly over 40%. And even those who do not have a family history may have a risk over 30 to 40% as well. So it works both ways. Unfortunately, we're not quite at the point yet where we're doing this kind of specific prediction, but some of the commercial laboratories are, and it's possible within the context of the CAN-RISK model. So to summarize, polygenic risk scores are strongly associated with risk. Scores that have large numbers of SNPs have reasonably high discriminatory accuracy, but still a lot of breast cancer occurs in women who have low to intermediate scores, particularly if you're using fewer SNPs. There is the potential for benefit, but whether or not this works for individual absolute risk prediction is as yet not completely clear. And the calibration of the estimates is starting to become evident, but we're waiting for complete data. The other complication is that most of the polygenic risk scores have been based upon SNPs that were defined in European populations. And so the challenge is now applying this to multi-ancestry populations, and there are some very complex ways to do that using ancestry decomposition and then ancestry-specific SNP component scores. But that requires a fair amount of math, and unfortunately, we don't have as good estimates for the odds ratios associated with SNPs in non-European populations because there haven't been so many included in the available studies. So the final thought on this is that George Box, who was a statistician, said that all models are wrong, but some are useful. And I think that's where we're at with empiric risk prediction for breast cancer right now. They are pointing the way, and I don't think we're far off from being able to incorporate all these things into a single model. But it is going to require, of course, universal SNP genotyping at the same time, and that is not currently available through most commercial laboratories. So thank you very much. I hope that that's helpful. And if I am off the plane, I will try to join you for some questions and answers. So thank you.
Excelente presentación. Doy paso al doctor Ernesto Gildesa para realizar las preguntas.
La verdad es que ha sido una presentación extraordinaria a la que nos tiene acostumbrado el doctor Robson, que es brillante sin lugar a dudas y que nos plantea el problema de si podemos o no determinar riesgo en la población que no tiene alto riesgo genético tal como nosotros lo conocemos ahora. Y entonces le formulé dos preguntas que quería compartir con ustedes al doctor Robson. La primera es si este sesgo en los test actuales de riesgo poligénico con ancestros europeos nos debía hacernos prudentes en la aplicación en poblaciones que son multiétnicas. Y esto es lo que él contestó, y es que claramente las primeras generaciones de estos test están basados en ancestros europeos, que las odd ratio, es decir, el riesgo en las poblaciones que tienen otras etnias como ancestros es más compleja de determinar, y que los test más nuevos están incorporándolos, y que es probable que en el futuro tengamos test mejor calibrados para una población general. Y la segunda pregunta estaba relacionada con la determinación del riesgo individual, teniendo la multifactorialidad, esto es, el hecho de que los factores de riesgo sean tan variados en una persona, pareciera ser un problema muy interesante para resolver con la inteligencia artificial, con modelos de inteligencia artificial que empleen o evalúen múltiples riesgos simultáneamente. Y él contestó esto, que claramente puede imaginar un algoritmo que contemple esta multivariabilidad, pero que el desafío es encontrarnos con series que hayan sido seguidas durante largo tiempo y que no tengan los sesgos de las series actuales para poder responder a esta pregunta. Pero es posible que en el futuro podamos determinar con mucha mayor claridad el riesgo individual utilizando la inteligencia artificial. Les agradezco muchísimo la gentileza de haberme invitado y les agradezco toda la información que nos han dado. Muchas gracias, Karina, muchas gracias al doctor Sheckman por la invitación que han hecho.
Los esperamos el sábado próximo 28 a las 10 a.m. hora local de Argentina. Recuerden que para obtener la certificación que va a entregar Umberto Veronesi Academy y la Universidad de San Diego, California, es necesario participar en los dos encuentros. Van a tener después también la posibilidad de volver a verlo, pero es necesario estar presente en los dos para poder acceder a estos beneficios. Agradecer a los 1.200 participantes hoy en vivo que nos han acompañado a lo largo de la mañana. Agradecer a los disertantes que, como dijiste, Darío, son de nivel internacional, al doctor Gabriel Farante, a la Umberto Veronesi Academy por confiar en nosotros dos, confiar en CLIM, la comunidad latinoamericana de imagenólogos mamarios, por darnos este espacio, por volver a presentarnos nuevamente este año. Recuerden que al final de esto va a haber una encuesta que agradecemos que por favor completen. y agradecer como siempre a todo el equipo de Tecnoimagen, a sus directivos, a quienes nos acompañan hoy, a Ethel, a Alex. No quiero olvidarme de nadie, también a las intérpretes que realmente han hecho un trabajo magnífico. Hoy cumplimos con todos los tiempos, agradecerles y queremos leerlos en estos mensajes. Darío, te dejo cerrar. Gracias.
Gracias, Cari. Sí, yo también quería agradecer, como dijiste, a toda la gente que nos acompañó. Realmente las clases fueron de un nivel superlativo. A los moderadores que se ocuparon, que nos ayudaron a hacer todas las consultas y las preguntas. Obviamente a Tecnoimagen, a las intérpretes, a vos, Cari, por siempre poder trabajar en forma tranquila. Y también quería agradecerles a todos que algunos me escribieron por chat o por mail de la situación. Les cuento que por suerte yo estoy bien, que la familia está relativamente bien, aunque estamos todos muy tristes y angustiados por lo que está pasando. Y bueno, y esperemos que todo esto pase lo antes posible y que sea para mejor para todo el mundo. Saludos para todos y gracias a todos. Gracias por el cariño y por los mensajes de aliento. Gracias.